Good morning. I'm Jonathan Arend, Associate Professor of Medicine at the Icahn School of Medicine at Mount Sinai. I also serve as Medical Director for Population Health for the hospital-based practices at Mount Sinai. On behalf of the Icahn School of Medicine at Mount Sinai and Healthfirst, I'd like to welcome you all to the second annual Best Practices Conference, Reconsidering Healthcare in the Era of Pandemics. Thank you for joining us. Dr. Susan Bean and I are co-directors of this continuing medical education event, and we'll be the moderators for today. Before Dr. Bean introduces today's theme, I'd like to thank and recognize our planning committee and those who are instrumental in making today's event possible. Dr. Robert Fields, Cheryl Markowitz, Steve Ruth, Elizabeth Jean-Jacques, Latoya Norman, Sharon Clancy, Raymond Thornhill, and of course the Continuing Medical Education Office for the Icahn School of Medicine at Mount Sinai. I'll now invite Dr. Bean to introduce herself and launch into today's theme.
Thanks, Jonathan, and good morning, everyone. At Healthfirst, I serve as Executive Medical Director, and in this role, I focus on performance and process improvement in collaboration with our sponsors and providers. In addition, our team seeks to identify, design, implement, and evaluate models of care that can promote equitable health outcomes for Healthfirst members and their communities. The purpose of today's event is to increase knowledge of emerging strategies for addressing health needs and reducing racial health disparities among New Yorkers in the era of COVID-19. The objectives are outlined in your materials and include defining the health profile and accumulation of risk in populations most vulnerable to infection with COVID-19, recognizing challenges to achieving optimal health outcomes for patients and communities who are suffering from COVID-19 infection, especially as it relates to racial disparities and equity, identifying current and new models of care, social factors, and policies on health outcomes for the post-COVID-19 healthcare delivery system, and also implementing and finding ways that we might all integrate evidence-based approaches to reduce health disparities that are highlighted by this and other pandemics. So I echo Jonathan's welcome to all, and if you have not already done so, I encourage you to download today's materials. We will post a link in the chat box now and periodically during the conference. In addition to all of the presentations, in that booklet, you will find the detailed bios for our faculty. So here are some of our housekeeping rules. All attendees have been placed in listen-only mode. As you know, in a virtual conference, we communicate through chat and through the Q&A features. And these features may be used to pose questions to panelists at all times during the conference. We will ask that you use the Q&A feature for all topic-related questions. And the chat feature may be used for your comments, your technical questions, and even your applause if you would like to send some well wishes our way. But please keep in mind that in this virtual format, we will look forward to addressing and answering questions during the scheduled Q&A periods, and we've allotted plenty of time to hear from you and for you to interact with our panelists in that way. And then finally, as a reminder, this webinar is being recorded. So with that, I would like to introduce our special lecturer and our first presenter for today, who is Errol Pierre. Errol is the Senior Vice President of State Programs at Healthfirst. He is accountable for all aspects of the Medicaid and long-term care product portfolios. Errol will present on ethnic concordance between the physician and the patient and what it means for the future of healthcare disparities after COVID-19. Mr. Pierre, please begin.
Thank you, Dr. B. Thank you. And it's a pleasure to be here. So before I get into it, I just want to say that I fell into this research accidentally. I didn't really know what ethnic concordance meant, but I knew what it felt like. During my preventive care visits, when various doctors asked me personal questions about my health and my mental state, if they didn't look like me or emote that they could relate to me, I actually lied. I lied to my doctor. I lied for many reasons. I feared Perpetual stereotypes. I lied to avoid what I felt as someone would pass judgment on me. I lied because I felt maybe the truth might be embarrassing. And so that's what really started my journey in investigating ethnic concordance between physicians and patients and what it means. And then COVID happened, and then George Floyd happened. Next slide. So today, my purpose is to really go through an overview of the current literature on ethnic concordance and how it relates to disparities. I have no financial disclosures, and I ask myself a question every morning when I wake up. How do we handle these disparities? I do feel it's my highest duty as an employee at Healthfirst to try to solve that question. It's a conundrum for us. And at Healthfirst, we have the honor and privilege to provide access and high quality healthcare to over 1.5 million members every day. And so it is our job to try to solve this with all the help of the rest of the healthcare system. So you can see the slide, we're in a crisis, right? Our system is grossly inefficient. We spend more money, we cover less people, we have less quality, even though we have the same patient ratios as many developed countries. However, when you look at how homogeneous other countries are, you will see that that US's diversity trumps, no pun intended, the diversity of many developed nations. I don't look at the slide as a negative. Actually, I think it's a positive. It means we don't need more money in the system to fix it. We spend 3 times more than the OECD average, twice as more as the top 10 countries. So money is not the problem. It's a management problem. Next slide. So if you look at the leading causes of chronic disease, it's driven by high blood pressure, diabetes, stroke is the 3rd reason of death in the country. You will see that when people are young, the disparities are few and far between. There's no difference or a small difference between white patients and Black patients. However, every day living in America as a Black person, the disparities get worse, they exacerbate, and then you could see the differences in ages 50 to 64. Minor differences 35 to 49. And the question I always get asked about this slide is it controlled for age, education, location? It is controlled for all that, and these still disparities persist. And so right now, a Black man in the Bronx has a life expectancy of 76. So technically, I live in the Bronx. I'm going through my midlife crisis. But here's the beauty of the slide. A research study from 2011, Levice, Gaston, and Richard found that we could find more than $230 billion in eliminating healthcare disparities. $230 billion. For perspective, that's how much Congress passed just recently in funds for hospitals for COVID relief. That total increases to $1 trillion when you add indirect costs associated with premature deaths and avoidable illness. $1 trillion was what Congress passed for the PPP program through COVID. These are tons and tons of dollars that can be found if we can close the gaps and disparities. Next slide. So COVID reawakened the healthcare industry about these disparities. While my fellow colleagues and I were sent to work from home on March 17th during the pandemic, not all of our members found themselves to be so fortunate. Our members look much like my parents who came to America in the 70s. They're resilient, they're ethnically diverse, they're native and immigrant New Yorkers that don't always speak English as a first language. Many of them are essential workers, so they're not able to work from home. They earn average salaries less than minimum wage, $15 an hour. Many work in industries that are less likely to be done while working from home, representing families in New York City that live together in close proximity, and housing complexes that do not lend themselves to proper social distancing. So the sheer death and sickness that overcame many of our members was heart-wrenching for us to see. It was eye-opening, and we witnessed firsthand a disproportionate share of COVID cases and death rates that impacted both Black and Hispanic populations across the country. We also saw the stark reality that the survival rates of our fellow New Yorkers with COVID-19 depended more on someone's zip code of residence rather than their overall health. For example, a New York Times article showing a light that in Manhattan, there was more hospital beds per borough, 5 to every 1,000 people, as compared to Queens, 1.8 to every 1,000 people. And they experienced exponentially less COVID cases, 16 cases per 1,000, as compared to the Bronx, 33 cases per 1,000. So even if you're fortunate enough to be in Manhattan at the time of COVID, your chances of survival then depended on if you were sent to a private hospital, 11% mortality rate versus a public one, 22% mortality rate. Lastly, during this unprecedented season of suffering, we saw unemployment skyrocket. And with it, increases of food insecurity, rent burden that disproportionately impacted the same communities hit hardest by COVID-19. These job losses impacted communities differently than the past. Normally, if you look at Department of Labor statistics, foreign-born workers participate in the labor market more than native workers. It's 61.8% versus 59.6%. But COVID disproportionately impacted the labor sectors where immigrants found themselves working the most: restaurants, daycare centers, home care agencies, and retail clothing stores. Next slide. So very confounding. So what do we do about it? I think as a system and as a city and as a country, we need to draw a line in the sand as healthcare professionals and demand a better system for our patients, for our neighbors, for our fellow Americans. And so a 2018 study that was in Oakland, California, found that ethnic concordance could be a solution to reducing disparities. The study found that Black and African-American patients in ethnically concordant physician and patient relationships were more likely to agree to preventive care services offered as compared if they were in discordant relationships. So what does concordance mean? It's defined by Thornton, Powell, Roeder, and Cooper as the degree of patient and physician similarities or agreement across given dimensions, shared specific social characteristics like gender, like race, like social economic status, and like education. It also shows an alignment in expectations, beliefs, and perceptions that impact health and care quality. So there was a doctor, Dr. Thompson, back in 1974, who came out with the social accessibility hypothesis. And he contended that physicians find it very difficult to effectively communicate with patients, especially when there are cultural differences. And on that premise, the psychosocial accessibility problem with Blacks obtaining healthcare would greatly be alleviated through the existence of an appropriate number of Black physicians to meet the healthcare demands in the healthcare service industry. So basically what he was saying is, concordance is seen all across our industry. However, his Black patients and Hispanic patients have less options to find concordant physicians. And that's what he led to believe if we could increase the number of doctors to match our diversity population, we could actually decrease healthcare costs and increase healthcare quality. Next slide. But here's the problem. The findings aren't conclusive. This is a 2020 study, just came out in the Journal of Psychotherapy Integration, and it found no statistical difference between ethnic concordant and discordant physician and patient relationships. There are actually many, many, many studies, I've read them all, that find little to no statistical significance in health outcomes between ethnically concordant physicians and visits too. So that's why it hasn't become a groundswell in our industry. People talk about it, but there's so much inconclusive data. We haven't said this is a way forward. So if you go to the next slide, what I believe George Floyd and Breonna Taylor brought to the forefront was the concept of racial bias. We do have to ask ourselves about bias. 8 minutes and 46 seconds changed our lives. On Memorial Day, we saw the full spectrum of racial bias and racism. Amy Cooper in Central Park, except when she called the police showed up to a deli in Chicago Avenue called Cup Foods, where they apprehended a suspect who allegedly had a fake $20 bill in Minneapolis. We also see bias in healthcare. Fitzgerald and Hertz say implicit bias is defined as associations outside conscious awareness that lead to a negative evaluation of a person on the basis of irrelevant characteristics, such as race or gender. The one similarity between all of these research studies that find no correlation between ethnic concordance and patient outcomes has more to do with endogeneity than a simple lack of correlation. That is, many of these research studies in concordance fail to include the one very important variable in their regression analysis, and it's a variable that I do contend is the most important variable for this topic, which is implicit bias. And since implicit bias exists in our healthcare system, it also exists in the data we use to treat our patients. And this has become clear to even New York regulators, as you see in the article on the screen, who have begun to conduct investigations into algorithms that may have been foundationally built upon biased data, which led to perpetuation and exacerbation of bias in healthcare. This specific example, what the algorithm did was say, we want to find people who are sick. So they use cost as a way to say, we're going to stratify our patients based on cost. What ended up happening is cost became a hidden variable for Black patients. There was collinearity between cost and Black patients because Black patients weren't getting the same treatments even though they had the same diseases as their white counterparts. So by using cost as stratification, they actually, without knowing, blocked out all the Black patients from their algorithm, and they were taking care of healthier white patients before sicker Black patients, not because they were sicker, but because the healthcare system wasn't rendering the same care. What does that mean specifically? The reason why African Americans are less likely to be addicted to opioids, it's because when they say they have pain, doctors at certain points are less likely to prescribe the medicine. So since they're not prescribing the medicine, their cost for pain is less than their white counterpart. And so when you do an algorithm using data to try to stratify your members, you end up blocking out a whole class of people. Next slide. So when you add implicit bias into the variable in your research model and your regression analysis, there's now a statistical significance in health outcomes, and they begin to emerge. A 2018 meta-analysis reviewed 6,249 research studies and found that implicit bias absolutely plays a role in continuing healthcare disparities. In fact, with bias included, there are more research studies that show ethnically concordant physician and patient relationships lead to not only greater patient satisfaction scores, it's not just about satisfaction, it also leads to longer patient talk time. Physicians and patients actually talk longer. It leads to more physician effort, which is an interesting aspect. The physician goes out of their way to render more care, and then it leads to higher adherence rates. We all are struggling with adherence. Everyone's struggling with adherence. And in our Medicare model, we actually have a dedicated call center that calls members to remind them to take their meds. And here we found a doctor that's ethnically concordant and does not have bias leads to higher adherence rates. Next slide. So how pervasive is implicit bias? This is just one study. 2017 study from the Children's Hospital in Philadelphia found that 91% of their med students had a pro-white, anti-Black bias against Black children. 85% had a bias against Black adults. And these biases, the study found, led to poorer physician communication, disparities in medical treatment, which I talked about around opioids, and then lower adherence to treatment recommendations. And it brings me back to how I started this presentation. I lied to my doctor if I didn't feel that they could relate to me, if potentially I didn't feel a connection to them. Race it's more to do with than race. It has to do with culture. It has to do with a whole bunch of things. So that's why it's ethnic concordance as opposed to race concordance. Next slide. So here is a hypothesis. Physician bias, you can click next. The degree to physician bias will either improve or decrease physician communication. Next. And physician communication will lead to patient trust. Next. Now, ethnic concordance is a moderator on patient trust. So if I have low implicit bias, but I have high ethnic concordance, meaning a white doctor, a white doctor with low implicit bias, a white doctor with low implicit bias and does not have ethnic concordance, I can still get patient trust. Vice versa, if I have a doctor with high implicit bias that is Black and the patient's Black, even if they have ethnic concordance, I won't have trust. And this is the difference in the model, adding implicit bias as a variable. And when you have that patient trust, if you go to click next, you get to patient adherence. So this is the model that we're looking to prove. Next slide. So the first hypothesis, again, implicit bias consciously or unconsciously negatively impacts the ability for physicians to effectively communicate with their patients. And you can see the studies that specifically speak to it. Next slide. In physician communication, effective physician communication includes both verbal and nonverbal messaging to patients, and that will lead to an increase in patient trust. And I think it's important that you can call out, second bullet, it includes effective questioning, it includes transmission of information, and it includes the expression of empathy and concern, and participation in decision-making, which is very key in the concept of physician communication. And patient motivations and complexity of treatment that could involve lifestyle changes can be influenced by physician communication. So we always talk about patient behavior, and there are studies that say the right physician communication can lead to changes in patients' behavior, but that communication is thwarted if there is a presence of implicit bias. Next slide. So what is patient trust? Higher rates of trust between physician and patients will lead to either improved patient adherence or improved rates of patients' intent to adhere. And you can see the different examples here. And that's the concept that they talk about bedside manner. Those who express compassion for their patients, adherence rates were 3 times higher. That's an O'Malley study from 2002. Next slide. Lastly, ethnic concordance between the patient and the physician serve as a moderator, as I said, to patient trust. And in a study, again, Levice, Nuru, and Jeter, residents of each racial and ethnic group reported the highest levels of satisfaction if they were in race concordant relationships. Moreover, all respondents reported greater satisfaction with physicians from their own race. And then here from Street from 2008, patients' perceptions of similarities with their physician had strong correlation to patient satisfaction and adherence. However, perceived racial similarities were not related to health outcomes. Again, I want to stress this is not just about race. It has to do about the full package of what's considered ethnic concordance. It's culture. It's also other attributes as well. The best example on this is talks about a concordance in Oakland, a potentially Nigerian doctor who was Black, who has the same race as their Oakland patient, has less ethnic concordance than another white doctor who grew up in Oakland, because country of origin is different, food's different, language different, all of these things are different. So just the race doesn't make it a concordant relationship. It has to do more than that. Next slide. So the experiment, partnering with an FQHC, where we have patients from 21 years old to 64 years old, they were all given a $25 gift card. The appointments were booked randomly assigned, and the randomly assigned pairings between the patient and the physician were based on implicit bias and ethnic concordance, and they were offered up multiple preventive care services in increasing degrees of complexity and invasiveness. That's the setup of the experiment. Next slide. And how did we operationalize this? 800 invites sent, 3 times follow-ups. Patients take a survey before the visit to understand their likelihood to be with a doctor, and if they have specific requests for their doctor. Do they want to see a doctor that looks like them? Do they not? Et cetera, et cetera, et cetera. The patients were then round-robinly assigned to physicians that took an IAT test, which measures implicit bias. They began seeing the patients. The visits were tape recorded. We're still waiting on the final data sets. And then post-visit, after 30 days, we then did another survey, a post-survey, to find out their intent to adhere. Next slide. The measurements we used, implicit bias, is a 2007 measure, which is strongly used and validated. Patient communication, a 1998 scale around medical communication competency, which is widely used in research. Patient trust and patient scales, a 10 Likert, a 7 Likert 7 scale question, just 10 questions to measure patient trust. And ethnic concordance was used by a Street, O'Malley, Cooper, and Hydet scale, measuring the degrees that someone is similar. And then patient adherence was the intent to adhere questionnaire. And that's the measurements we use that are all validated in research. Next slide. So expected results, and I don't have the results yet, but I'm looking to have them over the next 6 to 8 months. But the expected results are Patient adherence will be highest where ethnic concordance between the patient and the physician are the highest, and implicit bias with the physician is the lowest. Thus, more preventive services will be rendered regardless of the level of invasiveness. And this is important because when we talk about preventive care services that are hard for people, like colonoscopies, we believe that a ethnic concordant, low implicit bias will actually increase the level of adherence to even preventive visits that are very invasive. And then the degree to higher levels of patient trust and effective physician communication will result. This is the regression analysis to measure all of the moving variables to understand the statistical significance. Next slide. So there are validity concerns. The first one, we're only using patients that decide to participate. So obviously, one can contend the ones that decided to participate are different than the ones that didn't. We also do assume that all physicians are created equal. So the experiment fails that if the physicians that we are using had different levels of expertise, experience. We do not measure the concept of physician effort. That was the one that was found in the Oakland study in 2018 that says if a physician is treating a patient where there's ethnic concordance, that they try harder. One of the reasons we didn't do that is it would confound the formula and would add more noise to the regression, so I decided to drop it. And lastly, we have conclusion validity concerns because when we're asking patients how did they feel after the visit, patients could be likely to want to say what they think we want to hear. External validity, and this is the issue that's been confounding this research for a very long time, is okay, it worked in Oakland, and okay, it might work in Brooklyn depending on these results, but who says it works everywhere? And there is actually research that shows ethnic concordance is lower for Hispanics that do not speak English, and the early research showing, Hispanics that do speak English, it's early research. And there's also research showing that it does not work in all ethnic groups. So there's still lots of questions about external validity onto other populations. Next slide. So with this research, and what I'd like to leave you with is expected contributions. I think we need to invest more in concordant research. Our industry needs to do more studies and more research. It is hard to find actual studies that use implicit bias as a variable in this types of research, and to do it more on disease states. For example, Dellis, Corliss, Young, Bell, and Tarbit found that there's no concordant research today on lupus at all. So they were trying to find it and they couldn't find it in a literature review. As I said before, not all ethnicities like Asian populations and English-speaking Hispanics respond the same to ethnic concordant relationships. So we want to understand why. That was a study by Traylor in 2010. Also expected contribution is the need to increase physician workforce diversity with clear targets and clear incentives. Diversity is the great equalizer in improving disparities. All medical patients are more likely to choose ethnically concordant physicians regardless of ethnicity. That was found in a 2010 study. However, Black and Hispanic patients are the least likely to have ethnic concordant options, which Cooper and Poe found in 2004. And as Dr. Thomas has shown, the ratio of Black physicians to the Black population in 1942 was 1 to 3,300. In 1976, it was worse. It was 1 to 4,000. And as of 2018, there's approximately 45,000 Black African-American physicians. They make up 6.8% of all the physicians in the United States. And as everyone well knows, there's 42 million African-Americans in the United States that make up 13% of the population. We also need to create data and AI ethic committees, which is starting, which I'm glad to see. As we move towards automation and companies move to relying on data science to sail and steer our strategic ships of growth, we need to make sure we have an ethical framework around our data so that when we're using decisions, we're not taking the sins of our past and continuing them because it's inherent in our data. And we don't want it to be the foundation for our future. And lastly, we want to extend the life expectancy for African-American males. It's the lowest life expectancy of any ethnic group in the country. And this will increase their exposure to both ethnically concordant physicians or other physicians with low or no bias. So this doesn't mean African-American males in this study have to see African-American doctors. It means we just need to make sure they're seeing doctors that have low or no implicit bias. And lastly, we're not going to fix healthcare without fixing all the social determinants of health. Everyone knows 80% of someone's health outcome has nothing to do with their access to healthcare. So we have to continue to work with legislators and policymakers to undo systemic racism and bias outside of healthcare in every working life that we have. Thank you.
Errol, I personally want to thank you. Ooh, I'm getting feedback. How's that? Okay, better. Errol, I want to thank you for that presentation. I learned so much, and I am going to, not sure why I'm getting feedback, but this is our Q&A.
I hear you clearly.
You hear me clearly? Okay. This is our Q&A period. I'm sure we all appreciated the importance of the material that Errol is presenting, as well as the work that he's invested in. Do we have any questions?
Yes. The first question is from Demetri, and he asks, or she asks, can skills to overcome implicit bias be taught?
So Errol, can skills around implicit bias be taught? That's a great question.
It is a great question. Yes, absolutely. So there's actually books. We actually had a presentation from Pamela Newkirk, who wrote a book about Diversity Inc. that talked about an $8 billion industry that was spent on improving diversity, and it talked about bias, and there's lots of bias training that occurs, and it showed that it hasn't worked. But I think acknowledging the bias exists and tracking things like talk time with patients, tracking things like assumptions, tracking things like how patients feel after a visit will help people acknowledge that it's happening. You have to acknowledge that it's happening first. And then you have to have a zero tolerance policy on allowing it to exist in your four walls. And so if people are not hired on the basis of how they treat patients, or if you're tracking complaints of patients and you start to see how come this, I mean, the study was so stark, 3-minute visits for patients based on skin color compared to 15-minute visits. And if you're watching that and you see that's happening and you show folks this is happening, it should change. So I do think it can change. People have to be aware that it's happening. That's why it's implicit, because people are unaware that it's happening.
Thank you, Errol. Helen, do we have another question for Errol?
Yes. The next question comes from Lori. Where does the gender of the physician versus patient come into play?
It's a great question. So the ethnic concordance scale I am using incorporates gender as part of the measurement of concordance. So country of origin is included, first language is included, race is included, gender is included, culture, social economic background, education, they're all included. Just by sheer fact that social economic background is included, there's already discordance between a physician and a doctor just because of a physician and a patient, just because of the salary difference. The doctor makes way more money than the patient. So you're never gonna have like 100% concordance. You just want as much concordance as possible. Gender is one factor inside the scale.
Thank you for that question. Helen,
Yes.
what's next?
We have a question from Laisha. Does the ethnic concordance of office staff and other support staff, aside from the physician, play a role in outcomes?
Awesome question. I haven't got there yet. We're just doing physicians for now, but absolutely, just from my personal experience, going to a doctor's office, if you're treated rudely, if people just throw you the clipboard to sign in, if they don't make eye contact with you, if the office looks dilapidated, that absolutely plays into how you're going to feel inside the office, and whether you're going to tell the truth, whether you feel that they care about your care. I believe that it's absolutely a factor.
Thank you for that question. Helen, what's next?
Yes. From Mr. Singh, would it be helpful for all healthcare workers to take the implicit bias test?
I think so. It's a 15-minute test. It's validated by Harvard. You can Google it, IAT. I've taken it. I was surprised by my results. Everyone should know where they fall on the scale. It doesn't make you a good person. It doesn't make you a bad person. It just makes you aware of your bias. And once you're aware of your bias, you can actually change your behavior.
Great. The next question is from Debian. Do you believe skills building related to implicit bias should be included in the curriculum in medical and other training institutions? If so, what steps can be taken to make this happen?
I do believe it should be involved in the curriculum. The steps are, if you are a medical professional rendering care and someone's life is going to be in your hands, you should know if you have a bias, my personal belief. The maternity mortality rate we see, there's articles every week of Black mothers that are dying, regardless of income. So it has nothing to do if you're poor or not. Serena Williams had complications, so you can't be more richer than her. So it has nothing to do with anything. I mean, that is the great control. If Serena Williams can have complications with her birth and issues during her hospital visit, as well as a Medicaid patient in Brooklyn, something's wrong. And so absolutely it should be part of the protocol. And it comes from years and years of the assumption that a bias that African Americans are strong, they've dealt with slavery, they're basketball players, they're football players, they're big boned, they have big bodies, this perception that they don't have pain. And so when someone says on a scale from 1 to 10, my pain is a 10, it's not believed. And it's not believed because potentially there's a bias that they're strong, they can deal with it, they're okay. Or it is another bias that they're saying it to get the drugs because they have a higher proclivity to be on substance abuse. These are all things that are inherent in our system, it's inherent in our data. We have to be aware of it, or else we're going to continue to perpetuate everything that's happening.
Great. Our next question comes from Gay. She says she thought about meeting potential physicians at the start of their education, meaning a program between Healthfirst and our teaching hospitals. Do you believe this would be a start to the ethnic bias?
It sounds like a program Dr. Bean will have to create. I like the pitch.
Oh, Errol. Gay, that's a great question. Thank you. We'll work on it later. All right, Helen, next question.
Yes, the next question is from Pilar. Since racism is learned at a very early age, what are the expectations of real change when the doctor has implicit bias?
Yep. I meet with every patient for the same amount of time. And when my time goes up, I check myself to understand why. And when I want to be curt or when I want to be frustrated, I check myself and pause and understand, why am I getting frustrated? Why am I being curt? What is leading me down this path? And it goes back to awareness. These are behaviors, and it's implicit behaviors. We don't know we do it. And this goes both ways. African Americans are not immune from implicit bias as well. An example is, if you might have a bad interaction with a police officer, you can have an implicit bias that all police are bad. And so you will treat a police officer poorly when they didn't do anything to you. This is not a race thing. And we all have implicit bias. We have to be aware of it. We have to control for it.
Great. Another question from Sarah. Some systems have incredible diversity, but there is a perception and concern that implicit bias takes too much time away from patients. So what do you suggest for systemic change amidst competing routine time constraints, and how can leadership support their own staffs in being less biased?
Yeah, I commend the hospital, Children's Hospital in Philadelphia. I mean, it's pretty courageous to release that study. The CEO that was there, and I don't know who the CEO was at the time, had to have seen the research, and to publish it is scary because what could be the backlash with that kind of results? It's public. You can Google the study. But what it did was allow other people to research the issue. Every hospital should ask themselves the same question about their facility, and that's the change. So one of my number one recommendations is we have to research this more because there's not enough research, and that's why I'm doing this research so I can add to the research. So someone else after me will do a literature review and potentially find this paper if it ever gets published, knock on wood, and continue the research. We need more research in this area.
Great, thank you. The next question is from Claire, and she asks, does gender and place of birth factor into the concordance?
The ethnic concordance scale I used, and it's in the slides, does use gender and does use country of origin. It's one factor in the scale. So think of it like a scale from 1 to 10, and you just check off all these things, right? Dr. Bean and I both live in the Bronx, check, right? Dr. Bean and I are in the same social economic class, check. Like you check all these things. You could have 8 out of 10 concordance, you could have 2 out of 10 concordance, and so it's a scale.
Great, thank you. So Claire's second question is, does Healthfirst have any incentives to reward quote unquote unbiased providers or those with improved behaviors?
Today, we do not. We do use quality metrics. I think indirectly, a physician with high quality, one can surmise that potentially there's low bias. That's a reach. I already see Dr. Bean's eyes looking at me.
Yeah,
but
I'm in agreement with you. I think that the physicians who participate in our quality program are actually incented away from implicit bias. They themselves would tell you that's not enough, but I do feel that it's not just the fact that we have the program, but how, for example, Errol spoke about patient experience, because we also incent around the experience patients have. If you think about Errol's presentation, that sort of moves you into the arena of having to think about how your patients are experiencing their care. So I think that's a great question.
Great. And we have a question from Russell, and he asks, how does the digital divide, which still exists, between the haves and the have-nots, play into all of this?
It's a very interesting question. So in a perfect world, every patient could look up a doctor of their choice, like ZocDoc, leverage a platform like ZocDoc to find if they look like themselves, what their background is, if they see some kind of connection between them and the physician that they choose. The digital divide, I think, erodes the ability for access and concordance to occur. Because if I don't have access to the internet, a digital phone, all these new technologies, the ability to download an app on my phone, because I have a phone from the government where I don't have either minutes or the ability to download an app or the ability to use the device, it impacts my ability to get to concordance. So there's already shortages in physicians, and then there's even more shortages when you look at concordant relationships. And then I think that the digital divide erodes it even more, the ability for a patient to get to a concordant physician, if they so choose,
Great. The next question is from Hetal. And the question is, the non-accessing patients at Healthfirst, meaning those not engaged in care, do they have something to do with ethnic concordance? Does that affect ethnic concordance?
I don't have evidence. My assumption is it has to be a factor. It has to be a factor. The only reason why I go to the doctor when I'm healthy is because I'm comfortable with my physician. If a doctor called me to come in and I didn't have a relationship with my physician, I have a lot of other things to do. So why would I go in for a preventive care visit? If I do trust my doctor and I believe my doctor has the best intent for me, and it's not a transactional relationship, it's actually a rich relationship, I'll be more inclined to listen to them. And so we give all of our doctors their roster lists. They have the ability to call the members and let them know about the preventive care visit. If the connection isn't there, it could be digital divide. Maybe the member changed their phone number, maybe the number's wrong, they don't have enough minutes, but it also could be concordance. I can't find a doctor I'm comfortable with.
Great.
Errol, let me follow up on that, because that is an area that Healthfirst is very, very interested in, access to care as well as equity. And I totally agree that this is an area that we could think about exploring more, really convincing. But what about the system itself? I mean, you know, it's sort of system on top of system on top of system. And sometimes we are not really able to discern all of the factors around access. Do you think there's some other variables that could, you know, sort of mitigate the opportunity even to get to that trusted physician that are, you know, for a member?
I do. You know, I know how blessed I am to choose a physician at will for what I need at any point in time. If I'm going to be in Wall Street at work, I can book a doctor for 30 minutes, leave the office, see him, her, and go back to work. And then when I'm in the Bronx, I can see my PCP, and wherever I go, I know I can get care wherever I want. Our members don't have that same luxury. One, they have to change their PCP because of our model. And then two, that freedom of access, no matter where you want to go, does not exist. They don't have the same ID card I have. And so I think it absolutely plays a part in it.
Great.
Thank you so much.
Errol.
Helen, I think we have time for 2 more quick questions before our time is up.
Okay, great. This question comes from Carol. How does the clinic versus the private practice impact care and outcomes?
It's a good question. I was shocked to see data recently from our head of physician network say that about 50% of our members go to clinics and about 50% go to private practice offices. I've seen high quality in both settings, but I've also seen complaints from members that they have a doctor, they build a rapport, and then when they go back to the clinic, they can't find them. I also think our members are smart enough to realize if they're able to see an attending versus a resident versus a doctor with many years of service. And that starts to show levels of care and levels of access. I don't have data, I haven't researched it to know if there's outcomes, but I think there is something there about what it feels like when you have a round robin approach to your care and you have different people seeing you all the time and it's hard for you to select the one that you want.
Dr. Dean, do we have time for that last question? Do we have time for
Yes,
one more
we
question?
do. One more question.
Great. The last question comes from R. Singh. Can doctors place a so-called concordance review on their website to judge their implicit bias or commonality so a patient can assess if the doctor can meet their specific needs? I realize digital access would play a role.
Yep. So we do that today. We just do it poorly. Every healthcare plan has a provider lookup tool, and you can choose language. Language is a part of concordance. You can't see the doctor's photo on many of the lookup tools, but on other tools that are attached to healthcare plans, like Health Grades or DocZoc, you can see the doctor's photo. So you can get to language in doctor's photo. The other pieces of it, yes, if the doctor wants to put in their profile, here's the country I'm from, here's, you know, all these other characteristics about me, you can do that. You can tell someone's gender on a lookup tool. So I think it's there, it's just not, I believe it's not intentional. And then I also want to leave off with saying, it's not just ethnic concordance. Ethnic concordance is a moderator to patient trust. You have to have excellent physician communication. So I can look like Dr. Bean if she's not a great physician, which she is, and I'm still not going to get good outcomes. It's not just ethnic concordance. And then also, you don't need to see a doctor that looks like you or is ethnically concordant if there's an absence of implicit bias. That's the other key. So what I don't want to happen is Black patients must see Black doctors, Indian patients must see Indian doctors, only if they want to. We just want to give the same access that everyone has to the type of doctor they want to see. And if they do see a doctor that does not look like them, we want to make sure that we can minimize implicit bias as much as possible.
Well, thank you so much. And thank you to our participants for all of those excellent questions. I know that we didn't get to all the questions. I even have questions for Errol that I'm going to have to forward to him after this conversation that we're having today. So I invite you to use his email address. It's on the program. And certainly feel free to contact him with any unanswered questions. Just join me in expressing in any way you can through this virtual environment your appreciation for Errol. That was really excellent. We learned so much. Thank you so much, Errol. Thank you,
Thank you, Dr.
thank
B.
you. And I will now turn the conference, this section of the conference over to Dr. Arendt.
Okay, thanks so much, Errol and Susan. A wonderful presentation and questions. Certainly resonates with me as a medical educator. By the way, we have the faculty here at Sinai have received some training in how to teach our residents in implicit bias in our precepting and you know, as they see their patients. So just scratching the surface. And I also just wanted to quickly echo Susan's comments about the Healthfirst quality program. I think that all of us at Mount Sinai are aggressively committed to caring for diverse population. And I think the Healthfirst quality program really helps to amplify and focus that effort. So, thank you for that. So I wanted to move on and introduce our keynote presenter, Dr. Robert Fields. Rob is Senior Vice President and Chief Medical Officer for Population Health at the Mount Sinai Health System. As CMO, he leads a network of over 4,000 physicians managing the clinical and financial outcomes of 450,000 lives across multiple contracts and all lines of business. Dr. Fields will discuss creating a new population health reality. Dr. Fields, please begin.
Thanks, Jonathan. Appreciate it. I trust everyone can hear me okay. I will also have a qualifier here that in the new era of Zoom, my dog has joined me in the office here. So if you hear snoring in the background, it's not me, it's my dog. So I will apologize in advance. But I appreciate everyone's time. And Errol, thank you so much for a great presentation. And I think without having coordinated our presentations, I think there will be some ongoing themes as I try to describe how Mount Sinai approaches the new realities in post-COVID and moving forward. Lots of things have changed for us, and I think the themes will be very congruent with what Errol has already described for us. So next slide. It may be helpful to, most of you know Mount Sinai, but we're a large academic health center, includes a medical school, we have nursing school, several community hospitals, and of course our main campus on the Upper East Side that I don't think there was anything that really signals the rather significant disparities in the physical location of the Mount Sinai main campus, with some of the most expensive real estate in the United States on one side and NYCHA housing on the other. And it sort of exemplifies the challenge that systems have in providing care to all populations, which is different, I think, than sometimes even certain venture-backed entities that do a great job of providing care, but the challenge of providing care for all racial and ethnic groups, all socioeconomic groups, is something we take on as part of our population health strategy. Next slide. Sinai has gone pretty far and very public in their path to population health, as most of you know. Several years ago, I would say that actually before Sinai was even ready, they were very public with ads saying, as the iconic ads now in the world of population health, if our beds are filled, it means we've failed. But it was really planting a flag for what the future looks like for us. We invested in new leadership, in growing our network, affecting the way physicians are compensated to a significant degree, all sorts of investments in how we move towards improving healthcare quality as defined by improved patient experience and improved clinical outcomes over a reduction in total cost of care. And that remains a pretty significant initiative for us. And frankly, now more than ever, and with all the pressures of COVID in terms of how that's changed behavior among our populations, I think more than ever, we've realized that this is the right work and it just needs to grow. Next slide. So March 17th, interesting that Errol, sounds like you started to work from home on the same day, but I recently went back to my office for the first time since March. And this was the date on my desk calendar. I sort of left it there as a bit of a time capsule to understand how our world has changed in that time, in these 5 months or so, approaching 5 months. At that point, we were still planning our strategy throughout 2020. We were just seeing our first cases in the hospital, not knowing that there were likely thousands of others that were already infected and that the virus was spreading rampantly in the communities. And we had no idea at the time. And frankly, a lot of us were still planning that, hey, we'll work from home for a few weeks and then be back. And not understanding that the landscape of economics, of business, of policy would change almost on a daily basis for the next several months. If you look at the next slide, we had planned in 2020 a pretty aggressive movement in pop health that focused on process improvement within our employed and independent practices. So our network consists of roughly 4,000 physicians. About 3/4 of those are employed and 1/4 independent practice. But we realized that in order to provide and achieve our goals and provide high quality care, we have to, raise all boats, as they raise all ships. And so that was focusing on both our independent and employed practices. Really, our operations were very relationship based. We have engagement managers that go into the offices, would spend hours there understanding the operations of an individual solo practice physician, and trying to help them adapt to the new payer environments and managing risk, financial risk for total cost of care. It's not easy. We don't go through medical school and residency understanding, we don't even go through medical school residency understanding small business economics and finances, much less larger policy issues in managing total cost of care. You just don't wake up one day as a primary care specialty physician knowing how to do this stuff. And so has been our job, is going to each site, trying to kind of get a sense of where they were on the phase of behavior change, and adapt to that and set specific goals and action plans at the practice level, working on clinical redesign wherever possible. And then using our analytics. So as many of you that know me know that social determinants has been really a key part of the way I approach population health throughout my career. And we've tried to instill that in our work here at Mount Sinai over these last 2.5 years. And using social determinants data in our predictive algorithms, for instance, we were functioning with a tool that helped predict the risk of an admission in the next 30 days. And that was augmented by social determinants data that was purchased commercially. So we could buy commercial available data, much like a Target or Walmart or some other store does to us today. They purchase data about us and use it for marketing. Well, we were able to use that and build it into machine learning algorithms to help predict all sorts of clinical and utilization outcomes, to help really try to get to a whole person context for our care management strategy. So not all folks that are poor have the same level of risk. Not all patients that are rich or middle class have the same level of risk. There are all sorts of other characteristics, as Errol explained. So many of the determinants of ultimate clinical outcomes in healthcare are not determined by our chronic conditions or our medications. There are all sorts of other things. So we were looking for ways to scale that across our population of now getting close to 500,000 lives that we're trying to manage under various contracts. We needed to understand that the global context at some scale. There was a significant attention on transitions of care, of course, which is a huge risk area when folks leave the hospital and generally, I think, underprepared or completely unprepared for the challenges of managing new or worsening chronic conditions once they get home. That was a huge focus of our work. We were still in the midst of, our network has grown pretty dramatically over the last few years. And so thinking about a practice on the Upper East Side and how that's not the same, or how it is the same and how it's different from downtown or from Queens or from Brooklyn. So we have to address those issues differently. The patient demographics are different. The needs are different. I mean, borrowing on Errol's themes of culturally competent care, we have to keep that in mind. And so the action plans that you take on need to have that community context associated with it. So dividing our network into geographic and also administrative units to really develop specific action plans was part of our process, and a greater dependence on in-person relationship-based approaches for care. This is all part of our pre-COVID strategy. It all made sense. It was certainly work intensive and face-to-face intensive, but certainly that didn't happen after March. Our ability to go into the practices was taken away. Our ability to work together in person in a room and draft and problem solve these major issues about how we're going to improve quality, reduce total cost of care, is now rearranged in this rather artificial format of video and Zoom meetings that we're all a part of now. And so it changed pretty dramatically. Lots of other things changed, though, that were almost existential for a lot of our doctors and a lot of our patients. I mean, obviously the economic crisis affected our patients in a pretty significant way. And that's a gross understatement, I know. But we started to see patients calling in with worsening behavioral health conditions. Even those that previously did not suffer from depression or anxiety found themselves anxious, stressed, and depressed. Anecdotally, rates of or expressions of suicidality were on the rise among our social workers on the team. So we started to see that happen more and more, and so we had to address that pretty clearly. We saw issues of food insecurity rise dramatically, literally overnight, when that started to happen. So we really needed to reassess our approach to population health in a pretty substantial way. For our physicians, it was existential for them too. I don't think that the average patient really, I was an independent doc. I had my own practice at a residency in North Carolina for several years. I don't think that patients, nor should they really, honestly, but I don't think the average patient appreciates the small business aspect of running a practice and what it means. And again, I don't blame patients for that. They shouldn't have to worry about their physician's business, but it is nevertheless true that when our physicians were seeing their volumes decrease and were grossly underprepared to approach care with telemedicine approaches or things like that, we saw our physicians were hurting and expressed fears that they would not be able to stay open over the next 90 days. We actually surveyed many of our practices, and more than 2/3 were worried about were reporting days cash on hand of less than 120 days. And so it is existential. And frankly, if it hadn't been for some of the federal programs, I think we would have seen a worse hit. So there were a few themes like that that emerged. And if we go to the next slide, and we can actually just click through the build here. But we saw several themes arise that we had to deal with from a population health standpoint. Our FQHCs were also suffering. They saw their volumes go down. When you think about access to vulnerable population, access to care for vulnerable populations, I think our FQHCs are at the front and center of that. And our safety net practices were really hurt. There were layoffs in many places. Some were fearing that they would not be able to stay open. As I mentioned, food insecurity was a major issue. Access was a major issue. Patients don't wake up one day just knowing how to do telehealth. You know, if that's not what you signed up for, there are certainly purpose-built practices that have virtual care as part of their model, but that isn't true for the majority of our practices and majority of our large academic health systems. You know, we had roughly about a couple thousand televisits over the course of 2019. We were doing 5,000 a day at the peak of COVID. It's unbelievable, the growth, but that took time and energy and effort. As was mentioned in the last presentation, disparities in technology, the digital divide, is a major theme that we are actively addressing now, because we realize while there is tremendous opportunity, there is tremendous risk, and I'll talk about that in a little bit. Behavioral health concerns, of course, and I mentioned the vulnerability of our primary care practices. And of course, it exposed the tremendous lack of capacity at the peak of the virus. And we needed to think about new models of care. How do we promote virtual care? How do we do more at home? Because our brick and mortar institutions are not capable of dealing with the scale that the virus really put forward. Next slide. So we very quickly developed I would say a short term, but it feeds into the long-term strategy for population health. And so I would say there were three big themes with multiple facets within them, but certainly the big themes are, we needed to very quickly change our analytics to be, instead of utilization focused or specifically chronic condition focused, to a focus on who's going to be at risk for COVID complications and how can we proactively outreach to them so that they are better able to manage their conditions and to manage any potential COVID symptoms or complications at the point that they might contract the virus. And so there were a couple of things there that we spun up analytics, of course, to help identify high-risk populations, because what was happening, if you think about operationally in the clinics, we were used to a passive approach where patients would come in, they would make an appointment, they would come in, they would be checked in, and then vitals were taken and go into the office. The front desk staff was really used to receiving patients. After COVID, the patients didn't come for good reason. And in many cases, we proactively canceled their appointments. We didn't want them to come into a clinic if they absolutely did not have to and potentially contract the virus. So we had to flip that model and do more outreach. So from the pop health standpoint, we facilitated distribution of high-risk patient lists and actually developed scripts to help retrain, essentially convert front desk staff and MAs into care coordinators so that they could do that outreach to those patients. Telehealth was obviously a huge part of that strategy, but as I mentioned, people don't wake up knowing how to engage in it. So we had to do quick assessments and then training on how to use, for example, MyChart, since we're Epic, but also we had already started a process of our consumer digital team on the new digital experience at Mount Sinai. And that quickly spun up from just being a really limited use case in our employer-based clinics to now a broad-based population strategy for how do we engage in the digital experience with our patients. We actually started mass texting campaigns for those that had access to SMS text to do broad-based screenings on 5 domains. So that was chronic condition management, medication access, food insecurity, behavioral health needs, and then COVID-related symptoms. So mass texting surveys that those were able to participate could click through via essentially a bot-enabled technology, and then go proactively identify patients that had those needs so we can pair them with our community health worker partners in many cases, and also medical students and our own care coordinating staff. And then, as I mentioned, we developed training guides for our practices to flip the model from a passive approach to a proactive approach, and very quickly spun up plans that we had already started for how to engage community health workers. We had to fast forward that process really quickly for their assistance, because this scale of the outreach was more than our team could possibly take on. Next slide. So there are some new emergent themes that are clear on the last couple of slides here. Telemedicine is a big one. And when we look to the future, and from a national point of view, and my colleagues in other systems, and even from policymakers in DC, telemedicine is a theme now that we've learned in this new reality that is absolutely critical. There are shifting policies. At the peak of it, it seemed like almost every day there was a new change in payment mechanisms and regulatory guidance on telemedicine, and that will continue. There are, I think, a few major issues that persist there that we'll have to, all of us, I think, in our various contexts, will have to pay attention to. One is the payment mechanisms and payment parity for telemedicine, whether that will be the same as in-person visits or not. And then what counts as telemedicine? You know, is it simply a video visit? Can it just be audio, and are there differences? I think we're all aware about how much communication occurs in nonverbal ways. And so the loss of that, how does that impact care? I think that's all really new and a little unclear. And the policies obviously are also a little unclear what the future holds there. There obviously are increase in volumes that has demanded a change in infrastructure for telemedicine, that's for sure. I would say that on the whole, the patient experience and also the physician experience and clinician experience has been generally positive. It's far from perfect, but the ability to be able to see someone's home context. I mean, what you certainly lose a lot of the in-person face-to-face engagement that I think is critical. And so it remains hopeful, but I already feel that sense of loss for our physicians in terms of not having that in-person visit. However, it also reminds me a little bit of home visits, because now you're seeing the spouse, the kids, the cousin, the friend that's living in the home. You see the home context a little bit. So that's universally, we're hearing that from our docs. And then obviously the use of peripherals and technology to guide and to augment visits is also a key theme. You can click through. Remote monitoring as an offshoot of that, I would say that not just in the typical telemedicine context where it's a video exchange with the patient, but we're looking at how do we inevitably are going to need to manage chronic conditions at home, and realize we learned a lot about our abilities to be able to do that successfully without having the typical model in place that maybe puts people at risk. It has to be empowered by team-based care structures. So we use clinical pharmacists in our model that can prescribe and titrate medications in conjunction with primary and specialty care. It's a way of improving access and getting to better clinical outcomes. And frankly, the patients would prefer in many cases not to have to take either public transportation or other transportation into the clinic and put themselves at risk, or frankly go through the inconvenience when they can be managed successfully at home for a lot of these. And the cadence of management is also improved with remote monitoring, real-time monitoring. I can describe clinical examples already from our experience in these last couple months, where we have either exceedingly low blood pressure or a really high blood pressure that we've been able to manage in real time with the focus on patient engagement. But that obviously implies that we deal with the digital divide issue that I'll just talk about in a minute. Next click, please. And then what we're also seeing from a pop health standpoint and a value standpoint is the economics of this and the shift to more government sponsored insurance plans, and specifically Medicaid. And then also, honestly, our uninsured population is likely to increase quite a bit as well. And so that's going to affect access as has been described earlier. So next slide. So actually, if we can click through maybe 2 clicks. So there are a few other themes that came out of this, and I will be the first to say that it is a shame that it took these things to bring as much awareness and energy into dealing with these issues. But that's what it's taken. These are not new issues. I mean, if you think I know enough about the history of healthcare and I'm self-interested enough to have read, I think the gross injustice that exists in healthcare has always existed, whether it's medical education or really in the delivery of care. But there are some main events, obviously, that triggered a I would say, a renewed awareness, and now hopefully more than that, an action to address these issues. And certainly the murder of George Floyd and Breonna Taylor, the differential in COVID outcomes that have now been well publicized, and then the economic impact of COVID. And if you click through all of those and other themes as well, you can go ahead and click through. You go ahead, yeah, all the way through. That's fine. And that has highlighted several issues. This is not an exhaustive list, but these are the things that we're immediately thinking about. As I mentioned, the digital divide, and how we use, what is our strategy as a system? What is our role as a system and community partner to close that digital divide and improve access? Because when you think about it from an operational point of view, developing the technology and the infrastructure to provide digital care offers amazing opportunity for access, on-demand care for vulnerable populations, and access to not only healthcare, but social care and care coordination. Tremendous opportunity using technology, but it is only accessible. You can only participate in it if we close the digital divide. And interestingly, in education, they had to solve that problem really quickly. We've spoken with the chief technology officer of the city and the chief technology officer for the Department of Ed in the city, and they distributed is north of 200,000 iPads. They had to change the cell infrastructure to deal with the broadband demand. They were able to do that really quickly out of necessity. There was not the same sense of urgency on the healthcare side, but there needs to be. And so that we're certainly discuss in the Q&A section if it's helpful, some of how we're approaching that and our strategies there. Obviously the differential in outcomes, and we're actively doing things to improve access and reduce disparities in access to hopefully lead to improved outcomes. And then the idea that and I think Errol spoke to this very eloquently, there is a great amount of mistrust in vulnerable communities with healthcare systems for really good reasons. And so I think to look in the mirror a little bit as a healthcare system and decide how we're going to change the way we engage with our communities to establish trust again, because for various reasons that doesn't exist today. And I think part of how we get there is that last element is we are actively looking to how to engage community health workers and nonprofit partners in communities to kind of get to a better outcome there. Next slide. When I think about, I give a talk to medical students about how population health, I view it as a vehicle for social justice. And I feel that way for several reasons, but I think from a financial point of view, I use this slide as an indicator. This is an old slide, but it's no less true today than it has been. There's often a comment about how the US overspends on healthcare compared to other OECD countries. I think there was a slide like that in Errol's presentation, which is absolutely correct, obviously. And our outcomes are among the worst of those countries. So all that is true. But if you take, some of you have also seen this slide, where if you look at public health spending and healthcare spending together, we're actually not radically different compared to some of our peer countries. The difference is in our spending. The distribution of spending on healthcare versus social care is skewed, in fact, inverse of many of our peer countries. And so you can take a couple different strategies here. You can hope that our policy will change, that we'll invest more in social care and flip that. You can call it a pessimist. I would say a realist, that I'm not seeing our country has the political will to flip that aggressively. And so what I hope is that by participating in value-based care and taking on greater financial risk, we will prove that investments in social care using healthcare dollars is going to be a sustainable model long-term. And that's frankly why I do what I do. Next slide. So I think I mentioned community partners as part of that strategy. I think that the way to invest is to encourage nonprofit partners, and I've used partners in a very strong way. This is not just a superficial relationship. Partners in healthcare, they need to be able to participate in healthcare financing in a meaningful way in order to make it sustainable for them, and frankly sustainable for us as part of our value-based care strategy as an augmentation to typical care. And that means that we need to invest in those social determinant drivers to improve outcomes and in the patient engagement pieces. I mean, I think all the things that Errol pointed out are exactly right. It's not simple to just access alone isn't enough. It's the right access that has to match the individual, and it has to be convenient and reasonable for them, because the barriers are great. And that includes technology and how we manage chronic conditions, standards of care, things like that. And I do think that the participation of CBOs in this model to not only improve their sustainability, but to also understand what the drivers are, and be really more facile with the healthcare economics and financing is going to be important for both of our strategies on the nonprofit and community side and on the healthcare system side. And then new process and technology to facilitate those relationships. But again, that really mandates that we have to solve the digital divide problem. There's a tremendous opportunity here to do this really well. If I don't think it's a money issue, it's a will issue of investing on the digital divide piece. So last slide. I think, I think overall as a population health strategy, we had to reimagine how we engage with our patients and physicians because of all the different dynamics that were occurring. And then while we focus early on COVID specific needs, it really opened the door to lots of other needs in terms of chronic condition management via telehealth. How do we continue to engage with our patients on social needs? We were already working on that, but it became even more an imperative really for us to really move in that direction given the stressors of COVID. And what I am very nervous of is that continual impacts of repeated waves of this over time that will impact our patients and our systems, and then really the vulnerability that we've already seen in our safety net that I'm very concerned about. And I think that the issue of equity, as Errol pointed out, is we should have been dealing with this decades ago, but at whatever time, even if now is the time, and moving forward, it has to be a strategic priority for systems, because we will not be successful if we don't have equity in mind in everything we do, and how we hire, how we mentor, how we care for patients, in the distribution of access and quality care has to be dealt with aggressively, and in a very transparent fashion. And I think that investments in communities are the way we move forward. So I appreciate everyone's attention. I think my email's on the next slide, and look forward to questions you might have.
Thanks so much, Rob. Appreciate that. That was wonderful. Especially appreciate the very clear depiction of why you do what you do. I think that really encapsulates that nicely, that slide. Thank you for that. Helen, do we have any questions for Dr. Fields?
I know there are no questions in Q&A right now.
Okay.
Man, I was super clear.
Well, one thing I was certainly curious about hearing a little bit more of, as you alluded to, some of the activities that Mount Sinai Health Partners and Population Health at Mount Sinai has been engaging in with regards to trying to close the digital divide.
Yeah, it's a great question. I think without getting into the details of how we got involved, which are, I think, less important, what we realized in some of our initial efforts is that this is really complicated. It's not as simple as distributing a bunch of devices to people and having it work out. In a couple of groups, we've kind of organized the problem in a few different domains. It's certainly devices is one piece, and frankly, matching the right device to the right patient. So a smartphone doesn't necessarily work for everybody because of dexterity issues and things like that. So that's one issue. And then there is and related to that, the patient engagement issue. Sometimes it requires education. You have to teach patients that this phone is not just to make calls. You can access all sorts of resources with it. So that takes work. That's relational work. There's no easy way to do that. And then there's a broadband and Wi-Fi issue, because it was initially when we started looking at this, there's the Affordable Care Act phones, the Obamacare phones that people had, but often those did not have the data capabilities and infrastructure to participate in the new models of care. So they were insufficient. So there were issues like that we addressed. And so we, instead of frankly going for the big bang that seemed like that was going to be harder, our strategy has shifted to where does infrastructure already exist? And can we use that existing infrastructure to then engage folks in healthcare and social care if that infrastructure is not being used for that purpose? So here's one example. We are having conversations with a charter school in East Harlem that primarily serves 2 NYCHA complexes in East Harlem. All their kids, about 1,200 kids, are all really vulnerable by almost any definition, socioeconomic, by the race distribution, the clinical outcomes, behavioral health outcomes. I mean, it's you know, they suffer from all the same disparities we're seeing throughout the rest of society. They, of course, like other educational systems, had to figure out how to distribute Chromebooks. They did cellular-enabled Chromebooks for all of their kids. And so that's an opportunity for us, right? They were using it for education, and frankly, their teachers were serving in a way like community health workers or care coordinators by doing wellness checks in the family, even after the school year was over, to make sure that they were getting what they needed. They were trying to access food for their families. I mean, they take a pretty comprehensive approach. Well, we can help with that. We have a whole team of social workers and nurses that can assist them and provide supplement to that. And so we're talking with them about where do we have patients that match, and then using their existing infrastructure they've already provided, how can we then consent them appropriately and have them understand, hey, they can link to our services. So let's engage in a virtual visit with their primary care or specialist doctor as part of the family, not just the kids, but the parents and the cousins, and everyone that lives in the household. We were able to match fuzzy matches on household to understand where we have shared patients and connect them to appropriate care, and then to our social workers to access food and security, things like that. So I think, and we're replicating that strategy in smaller ways in different areas where infrastructure has already been developed and distributed. And then you piggybacking on that to then engage them in medical and social care using that infrastructure.
Hi, the questions are starting to come in.
Okay.
So we have a question from Sawyer. How effective is the use of remote and telehealth monitoring to patient health? How effective is it?
Yeah, I think the data is actually pretty mixed on remote monitoring. And I would say it's really a victim of almost all health services research, is that there are an amazing number of confounders. And when you see one remote monitoring program, is this sort of cliche now, you see one, which you can say that about care management and all the other things. I think what makes our program different than the average remote monitoring program is the clinical pharmacist piece of that. And that we have frequent touches with someone who can aggressively manage the condition. It's not really that we're receiving a blood pressure reading and then we'll serve it up to the doc when he or she gets to it, and then they go back in their days. It's really real time and frequent engagement with the patient. We're also pairing it with our own consumer digital platform. So where possible, where the patient is able, we are using text and on-demand video, reminders to check their readings, things of that nature. It's the ongoing engagement. It's a relationship. It's not really the technology that I think is going to drive the improved outcomes. And I think programs that have taken that relational approach see better results, in the literature. But it is mixed. So we are certainly developing the program evaluation metrics so that we can prove that this model is going to be as effective as the most effective ones out there, or better. But admittedly, it's the technology alone doesn't drive it, and I think the data bears that out. I wouldn't say it's universally successful. Yeah.
Oh, yes.
No, please go ahead.
All right, no problem. So our next question is from Liz. So how can and should we continue the increased usage of telehealth? So should we?
So I would say without a doubt we should. There are many practical reasons for that. One is that I think we very clearly realize we don't need an in-person visit for all types of care. I think it's very helpful for some types of care, but it isn't the only way of doing things. So I think that's probably the most practical reason why we should continue it. But I think the second one, which is also practical from the patient perspective, our most vulnerable populations they don't have the flexibility or the access that more privileged patients have, but not for just insurance reasons. It's, can you take time off work to go to a doctor's appointment? Do they have that flexibility? Often not. Often it has to be a very specific windows of time, or they have to take time off. Vulnerable populations are more likely to have to take public transportation. Well, in the midst of a pandemic, that doesn't make a ton of sense. You take vulnerable populations, put them on a subway, or put them on the bus, or even on the medical transport that's group based. That's the worst place to put people. And so from a real just clinical care perspective, we should be encouraging them to use telehealth. So I think there are some real reasons to do that. And I think, you know, I didn't even touch on satisfaction, which I think, you know, I think that's another issue. But I think the other thing that's going to drive this is on the policy side. Right now in DC, there's you know work to try to contemplate what the future of telehealth is going to be. The CMS is or HHS has very clearly signaled that, you know, I think the quote from Seema Verma was that the horse is out of the barn. I think I hope I'm not misquoting her, but I think it's something to that effect. So I think there's a push to do that. What is a little less clear is what is defined within telehealth, because it's not all created the same, remote monitoring versus video visits versus audio only, and what will be the payment mechanisms. The reality is that the payment will drive incentives or disincentives to do that across systems. So I think we'll see. I think the other thing I would say that's going to push towards telehealth is that COVID very clearly exposed the pretty large cost structures that big hospital systems have. And so as they look to reduce their brick and mortar presence and reduce some of their costs, I think they'll look very hard at telehealth.
Great, thank you. We have a question from Andrew. How exactly are you screening for digital equity on an ongoing basis? Where is that captured? How do you assess resolution?
Great question. And I would say it's imperfect because we weren't routinely doing that before COVID, which was a mistake. But you know, we weren't doing as much telehealth or remote monitoring either. So I think there was less of a need. We very quickly pivoted to including that in our care management assessment. So we're doing it, you know, the old-fashioned way, which is as we're interviewing patients and doing their onboarding for enrollment and care management, we're asking a series of questions. It's not just simply, do you have a cell phone or not? It's a series of questions to understand where the gaps might be or not, and then try to figure out how we solve it from there. We have analytics that have mapped out based on publicly available data and initiatives that we know about across the city, and also used, if somebody participated in a televisit during this crisis, we use that as a surrogate, like they must have some type of access. So we're using surrogates like that to try to map out where we think the sort of, you know, I don't know if the right word is digital deserts. We know we have food deserts, but maybe the digital deserts or broadband deserts might be based on that information. So it's imperfect, unfortunately, at the moment. We're doing our best.
Great. We have a question from the chat room. What do you think about using data to help with disparities? Understanding all the missing variables the hospital does not see or does not witness. Is there an approach?
I think there is an approach, but I think the overall theme I would say is you should proceed with caution. I think Errol referenced one of the studies on one of his slides from Science magazine sometime last year that looked at the use of predictive algorithms on utilization and implicit bias that was built into that, because utilization itself is biased. It really implies issues of access and things of that nature. And so I think it doesn't mean that you don't collect the information and you don't look at it. It just means what you do about it and how you interpret the information has to have a sense of what biases are inherent in the data, because it is biased for lots of different reasons. I will tell you that we started to look at how do we actually measure, how well do we actually measure race and ethnicity in our operations? And it turns out we don't do a good job, that we're in about 50% of our charts, we don't have adequate information on race and ethnicity. So we need to figure that out, and we need to do that. So there are efforts there. So I think that's a huge issue. I think on the commercially available data, there's a tremendous opportunity there. It actually can fill a lot of the voids that we have in our own data because we haven't been asking the right questions, frankly. So I'm excited about the possibility of the commercially available data and what it does for our predictive analytics. I think there's opportunity, but I would say proceed with caution, with eyes wide open, and almost like you have to you have to assume that bias exists and just be aware of it when you go into it, is my opinion.
Great, thank you. The next question.
One more minute. Any further questions?
One moment. Yes. So we have a question from Tino. The biggest problem we kept facing, at least in the past, is that piloting and trialing out new technology to solve problems mentioned in the presentations in a closed loop manner in settings like Mount Sinai, for example. So is there a system in place to address that issue. Usually, we get lost in the permissions and paperwork in healthcare settings to even try out new tech, while on the flip side, the healthcare providers are asking for new tech.
Yeah, it's an excellent point. I'll try to be as efficient as possible, because I know we're short on time. I would say that one of the things that the virus did is remove some of those barriers. It's amazing what can happen, or how less conservative your legal teams can be when there's a crisis in place and you have to get stuff done. And that was true for the federal government too. I mean, they opened up and liberated policies that were inhibiting growth of these systems. So I think that helped in the crisis. And I do think there's enough inertia there, certainly on the technology piece, that I don't think we'll go back to where we were, because I think people realize, oh, the wheels don't fall off when you actually do this stuff. So I think that's all positive. However, there's still a great deal to do on the technology side and on the regulatory side that we need to advocate for. You know, I understand consumers are nervous, but about sort of sharing information. But I think something as simple as opt-in or opt-out for the health information exchange. Other states are opt-out. We're an opt-in state, and that really greatly inhibits our ability to coordinate with each other. Well-intended, but with really pretty dire consequences, I think, from a coordination standpoint. So I think I'm hopeful, because we have made tremendous progress. Things that I thought would take us years to put in place for all the reasons you described happen really quickly. So that's great news. And I do think that the federal government is aware of that, and will continue to facilitate some of this. So I don't think we'll go all the way back to the restrictive policies of before, but still a lot more work to do on the policy side to kind of get it to realize its full potential, I think.
Well, great. Thanks so much, Rob, for all that. Appreciate it. Thanks for the questions. At this point, I'll turn it back over to Susan to introduce our first panel.
Thank you so much. And I too want to add my appreciation to Rob and to that presentation. We are really, really off to a great start and keeping the momentum going. It's my honor to introduce our first panel. First, we'll hear from Pauline Jones, who's the Assistant Vice President of Nursing at Burke Rehabilitation Hospital. In her role, Pauline works closely with the Chief Nursing Officer and Executive Leadership Team to implement the mission, vision, policies, goals, and objectives of the organization and the nursing division in order to provide patient-centered care. For today's event, Ms. Pauline Jones will present on creating care plans for post-acute care in the COVID-19 pandemic. And after Pauline, we'll hear from Dr. Anita Iyer, who is the Director of Behavioral Health Population Management at Mount Sinai Health System and Associate Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai. She is a recognized leader in the innovative delivery of crisis services, a frequent speaker at behavioral health and suicide prevention conferences across the nation. And today, Dr. Iyer will present on emotional health in the time of COVID. And with that, I would like to invite Pauline to begin.
Thank you. Thank you for including me in this great forum. Next slide, please. Okay, so this presentation today, I want to first thank my Chief Executive Officer and senior leadership for us working so closely together at this trying time, challenging time. My objectives for this presentation is to talk about how Burke responded to the Governor Cuomo's executive order due to COVID pandemic, to discuss how we implemented our surge ward, to discuss the process by which we redeployed, reassigned, and educated our staff in this pandemic, and describe how the hospital met the complex needs for the patients, both medically and for their rehab concerns. Next slide, please. So as we know, we're living in a world of COVID. This pandemic is not only regional, but it's also global, all right? The global crisis that we have is for healthcare, for social, and also for the economy. Burke is located in White Plains, New York, which is 20 minutes pretty much from New York City, which is truly New York being the epicenter of this pandemic. We have 150 inpatient rehab beds. By that I mean our patients require 24-hour rehabilitation. That 24-hour rehabilitation is given by the nursing staff. They are here 24 hours. In the middle of this crisis, Burke transformed what we did in acute rehab to meet the needs of patients from our Monty healthcare system and our neighboring hospitals' medical crisis. Burke created care plans for the post-acute space. And for the post-acute space, I'm referring to inpatient rehabilitation. Next slide, please. So July 27th, we were known to have 50 million cases, 600,000 deaths. To date, this morning, we have 20 million cases, and we have 5 million cases in the US. The deaths exceed 738,000 globally, and in the US, 163,000. So those numbers in itself tells you that COVID is not going anywhere. And the question is why? The Monty Health System had over 200,000 COVID positive patients. When we think about COVID positive patients, pretty much talking about the disease that's caused by severe acute respiratory syndrome, coronavirus 2. Many of the COVID positive patients, initially when you think about it, you're thinking of patients that require acute hospital stay, medically complex stay. But after these patients are medically stable, then what? Then we find that these patients are deconditioned. They have disabilities, functional disabilities, where they cannot go home. And where do they go? They will go to a place like Burke Rehabilitation. But we had to position ourselves to care for these patients. As a point of reference, prior to COVID, patients that were admitted to Burke were screened for 3 functions. They needed functional rehabilitation because they were too deconditioned to go home. They needed 24-hour medical management. And they also were approved by their insurance company to come to Burke. Next slide. So then we had to come up with a process. Next slide. Phase 1, let's prepare. Senior leadership, our chief executive officer established a command center. The chief executive officer was our command leader. We met twice a day to discuss what we needed to do, what needed to be done, what were the regulatory agencies communicating to us, what was the New York State governor communicating to us. We had to position ourselves, communicate, communicate, communicate. That was important. Nonstop communication. No decision was made until it was brought to the command center where we discussed what we needed and how we needed to make it happen. As a result of the governor's order, we had to limit visitors. We had to limit access to our hospital. May I just go back? Burke being 150 bed, that's inpatient. We also have 6 satellite hospitals that did outpatient therapy and 1 outpatient center on campus. So when we closed, we collapsed in to meet the needs of the 150 beds, the 150 patients with their acute rehab need that was further complicated by their medical need. We had to re-educate our therapists that were outpatient because we did not want to furlough, and we did not furlough any staff members. We brought those staff members in, and we had them at the bedside to render care. We screened our staff, temperature checks, brief questions with regards to traveling, recent travel, any potential area that could potentially put our colleagues or our patients at risk. We had to increase the oxygen utilization. Prior to COVID, 40 of our 150 beds had piped in oxygen, but we knew because of COVID being this respiratory illness, we required more oxygen utilization. We had to create negative pressure rooms. We had to rent negative pressure devices, worked with our grounds crew to create negative pressure. We had to create surge beds. Our initial plan was to have 153 surge beds, but we only needed 14 at the time. However, we changed our infrastructure to accommodate 53 additional beds should we need it. We had to reorganize the patient referral process and screening process. Prior to COVID, we had a process by which we would receive the referral from all hospitals, our catchment areas worldwide. We would have registered nurses who would actually review the referring documentation, determine, give a recommendation really for appropriateness, and then send it to our physicians for a decision to admit. With COVID, we redesigned our screening process so it was doctor-to-doctor communication. With the CMS waiver, we did not have to wait for insurance approval. So we admitted patients that needed acute rehabilitation despite their medical needs. This posed quite a challenge to our staff. We were used to identifying patients that I mentioned before that was medically stable, for lack of a better word, to now having these patients that have probably been in ICU for 6 weeks or more, and so physically debilitated, now coming to our organization that were not the walkie-talkies, not the ones that participated in 3 hours of therapy, by definition pro-COVID, to now being so deconditioned, still required 3 hours of therapy, but how are we going to render that? Especially when we're thinking about social distancing, masking, the unknown of the diagnoses that they present with in terms of COVID status. That was always changing. When we reorganized the patient referral and screening process, we increased the turnaround time from what was typical 1 day to hours, which then posed the question or challenge, where are the beds for all these patients? Next slide. This is an illustration of our command center, our daily meetings. They were held 10 o'clock and 3 o'clock. And you see that because of social distancing, we all had to call in. So illustration on the left shows in the command center itself. And then the illustration on the right shows everyone calling in that could not be in the room. Next slide. So nursing had to redesign our model. For the surge unit, for example, we would have 1 nurse manager, 4 nurses on days, 3 nurses nights, and the ancillary staff is illustrated there. Just of note, each nursing unit was diagnosis specific, is diagnosis specific. After the implementation of the surge, we redesigned the case mix to include 1 nurse manager, 3 nurses on days, 3 nurses on nights, the aides, but then at the bottom too, you saw how we redeployed all of our ancillary offsite therapists to the bedside. So after we re-educated the therapists to do hands-on ancillary work, and as well as deliver therapy, we needed the case mix of 2 therapists during the days, additional, and 1 therapist at night, additional, and that was bare minimal. The good news is we had more help than we anticipated because more staff members wanted to help and wanted to be part of this mission. Next slide. Phase 2, how do we protect ourselves? How do we protect our patients? Our CEO had daily calls, all right, with the Hudson Valley hospitals in collaboration, in coordination with the Monty Health System. They spoke about what each hospital was doing, what worked and what didn't work. And then we brought that back to our 10 o'clock meeting and incorporated what worked or potentially would work into our system. We looked at the medical management and we looked at the rehabilitation management tools. For medical, we increased our hospitalists. As I mentioned before, we had patients that were medically complex, these patients that were in the ICU, in the telemetry, just in acute care for such a long time. So we needed the medical support. Our physicians are rehab physicians, but the current practice in acute care needed guidance. So we hired 4 additional hospitalists to work with our physicians to manage the medical complexity of the patients that required rehabilitation. The rehabilitation management, we had all of our therapy was bedside. No patient went to the gyms because of social distancing, because of COVID and the unknown status. Staff wellness, staff, they were upset. They were fearful. The unknown. Myself and the chief nurse, we wore scrubs. We went to the bedside. We helped the nurses at the bedside. We educated, we learned from them. And together we rendered the care that we needed to render to care for our patients. The morale initially was low because of the unknown. So we had to go around day to day, all the time, just to mentor and work with the staff and give them that, model the behavior pretty much, give them that hope that we're in this together and we'll get through it. The distribution and conservation of the usage of PPEs was quite challenging because you all know every day the CDC guidelines changed. And that was an exaggeration, but that's how it felt at the time. So we started out with giving surgical masks per CDC guidelines to every employee. Some employees heard from different hospitals, families, friends, that everyone was wearing N95. So we researched that with the health system and we converted mass distribution from surgical to N95 mask daily. We increased team rounds to twice a week because we had such an overabundance of patients coming to Burke for rehab, needed rehab, but we didn't have the beds. We didn't have the bed capacity. Even though we opened our surge unit, we opened 14-bed surge unit, but the surge unit required that we, on a daily basis, we had to meet with the team. Which patients could be safely discharged, ready to be discharged? Which patients could safely transfer to the surge unit so that we can accommodate the patient referrals that we were needing. Some of the challenges even with the patient referrals, because we didn't have a lot of oxygen. Piped in oxygen, we had to rent oxygen concentrators so that we could meet the needs of these patients. We needed mechanical lifts to deal with these patients. We have certain rooms that had ceiling lifts, but that didn't meet the needs of the patients that required to help with their care. We noticed that there was an increase in wound care because of the special COVID-related inflammatory vascular skin injury. Initially, we thought, oh my goodness, these COVID patients all had pressure ulcers, but how could that be? We rounded, we assessed them. How could that be? And then with further research, we realized it was COVID-related inflammatory vascular skin injury, and that we had to implement certain treatment strategies to work with that. Next slide. Next slide, please. So this is an example. We had White Plains Public Safely thanking the essential workers. This helped with treatment morale, staff morale. You see us out there waving. That made us feel good. The bottom middle slide shows temperature screening. These are all staff members that were therapists from therapy that we redeployed in and we reassigned. The daily mass distribution. These are all redeployed staff members that were able to assess and assist us in our needs. Next slide. So you can see with this slide, I just wanted to share the inception pretty much for us was in March with COVID, but we peaked at 90 patients. Today, we have 2 patients, COVID positive patients within our facility. Next slide. So phase 3, how to protect. What did we learn from our COVID experience? One, we need more private rooms. We need private rooms that have a window in it so we can constantly assess our patients. The challenges we had was we had our private rooms that we had to make rounds on, but then we had to don and doff PPEs. So if there was a medical emergency, and knock on wood, we did not have, it delayed response time. We want to focus on the patients that needed rehabilitation maintain internal medicine presence. So we went from adding 4 hospitalists, they had to go back, but we hired an additional. So now we have 2 internal medicine hospitalists that's working with us to care for our rehab patients that will be our medically complex. In addition to our infrastructure, electronic bedboard. Our typical bedboard, our bedboard right now is manual. So we slide the patient's name in, and then we identify where the patient needs to go, and then when they're discharged, we slide their name off. The downside to that is that we did not know when, if he wasn't in admitting where the bedboard is kept, we had no idea what bed was available and what bed was not, what patients we could move to the surge, what patients were discharged. So we would like to invest in an electronic bedboard, invest in the private rooms, invest in more piped and oxygen rooms, negative pressure rooms. Our current morgue size is for 2 patients, but if we do have another surge in the fall, we would like to increase our morgue size to accommodate more patients if we need to. And also when we speak about telemedicine, incorporating telemedicine into family meetings, patients that were in private rooms are sensory deprived, and we want to increase that in terms of connectiveness with their family. Next slide. Briefly, this is just showing the impairment group when we speak about patients medically complex that had COVID. We see here that in March, we had 23 patients, but by June, with COVID medically complex, we had 110. Next slide. Patients, we are proud to say that most of the patients that came to us with the diagnosis of debility as it relates to COVID, most patients went home, which is evidenced by this slide. Next slide. For our staff, what did we do? We received a lot of cards for cheer program. Next slide. We celebrated our 200th patient on discharge, our 250th patient. We had a high school student who made cards, and we had every patient who had COVID positive, their name went under the lung pictorial and was in our lobby. Next slide. Patients that were sensory deprived and families that came to visit, this illustrates how we had the grandfather, the patient, look out of his window with our assistant, and the family was outside wishing him a happy birthday. Next slide. This is another illustration of, because we couldn't have visitors, we used our 63-acre property to our advantage and allowed families to come outside, and the visitor and the patient would look through their window. Next slide. This is the use of iPads. We incorporate therapy time so that the family could speak with, the patients could speak with their family and FaceTime with their family. Next slide. And we also use virtual pet therapy to assist with sensory deprivation. Next slide. And also just for staff and how we wanted to support our staff and know that we are there for them, and we thank them and we appreciate them every day. Next slide. Thank you. And should you need to contact me, my information is here. Thank you.
Thank you. Hi, my name is Anita Iyer. I'm really delighted to be here to talk about a really important aspect of COVID impact in the world, which is the emotional health of our community, of ourselves, and of the people around us. A bunch of the speakers thus far have highlighted the impact of behavioral health and the need to attend to it. So I want to dive into that a bit more and present some of the sort of trends and data that we have available nationally in this regard. Next slide. So I'll briefly just highlight the factors associated with emotional reactions to COVID. I want to share some national trends, as I mentioned, specifically related to stress, anxiety, and depressive symptoms. And then I want to provide some strategies and resources really briefly that may be helpful for supporting patients. I'm going to have no disclosures. Next slide. You can skip this slide. So, emotional reactions to COVID, shouldn't be surprising. We've heard, I'm sure, in the news that prescriptions for anxiety have gone up. And we just know that any sort of situation that involves a mass reaction or a mass disaster, people have reactions to that. It impacts us. But this particular situation is somewhat different, right? The closest approximate that we have as a field to be able to look at what can we expect emotionally are situations like mass disasters, hurricanes, and so on, or infectious disease outbreaks. But COVID is different in that it started and then it's been lingering. And the responses, even the healthy responses to try to curtail the spread of the disease, has in itself sort of set forth emotional reactions on its own. So really, we're living in a very unique period in our history that presents unique challenges and unique solutions, perhaps. Next slide. So I wanted to briefly highlight, as I mentioned, sort of the closest approximate we have is infectious disease outbreaks or mass disasters, hurricanes and the like. In response to those situations, one would expect fear and worry about our safety, changes in our sleeping or our eating or difficulty concentrating, sort of your run-of-the-mill, if you will, telltale signs of depression or anxiety. But you also expect worsening health problems, medical health as well as mental health, often because it's difficult to get to your doctor's office and so on, and then increased use of substances. But specifically with respect to COVID and the types of situations that it has set up, obviously the fear of the virus, the sort of specifically initially when we didn't know exactly what it was, exactly whom it could impact and such, but then sort of the social distancing and the quarantine aspects that were put in place, which also are quite unique and not one that we have experienced at this scale for this long in our history as humans on this planet. So, you know, the disrupted social connections come with isolation and resulting depression. Quarantine stress in general has been associated with PTSD symptoms, as well as avoidance and anger. Obviously, grief is an important feeling set that comes up. Grief due to loss of loved ones, as well as grief due to the losses of what we knew our lives to be. Loss of routine, loss of income for some, loss of sort of the familiar. You know, I've heard colleagues talk about loss of the commute to work and sort of the little things that we didn't think were so restorative and important for our lives. There's also the financial stresses that folks are enduring and the depression and PTSD that can set forth. You know, particularly now with the aid running out and no clear sign of what to expect from a relief standpoint, that can exacerbate what people have already been feeling perhaps. Childcare issues, we'll talk later about sort of the impact on parents, particularly working parents. Feeling sort of exacerbated stresses such as from social determinants such as poverty, but on the other hand, perhaps guilt if you feel like you're at relative advantage compared to others. And then discrimination based on age, race, or other factors. Particularly early on in the pandemic, we heard of news reports of racial discrimination against Asian Americans, for example. I also wanted to highlight the specific stressors to providers among us. You know, we heard a bit earlier about what primary care practices and specialty care practices in the community had to do to scale up. We just heard in the presentation earlier about facilities and how staff had to adjust. So there's obviously those sort of adjustment related stresses, but there's also risk, worries about safety, worries about what you take home to your family, the need to learn new methods for billing and treatment very quickly, and then supporting your staff while you're also supporting and absorbing patient stresses. Next slide. I wanted to highlight briefly sort of subpopulations among us and unique stresses that they have. So the top left picture is indicative of couples or families. Obviously, we have disrupted routines, altered responsibilities, and divisions of labor, particularly if you have you know, one parent primarily working from home while the other has to go into the office with kids at home. That one parent who's at home may be now shouldering the responsibility of having to manage the kids' routines, their remote learning, keep up with schoolwork and so on, while also attending to their own home responsibilities. And their work responsibilities. New and worsened stresses that can prop up between couples. And then sort of the opposite of absence makes the heart grow fonder, right? Couples spending a lot of time together, and what does that mean and what does that do to their relationship? Older adults obviously experience the fear of being, quote, high risk, the fear of their losses of their friends and their family members or members within their community. Disrupted social connections obviously is a huge one. And then maintaining their preventive care and difficulties with that. And then we've heard a lot recently, in particular in the news media, about specific stressors for kids. So kids, you know, sort of may express specific fears related to COVID or perhaps some diffuse fears, really not knowing exactly what's happening. I borrowed this quote from my younger child that breaking news is scary. She's 6 years old, you know, but what she meant was that the ticker that's constantly moving on news channels constantly reporting scary news, you know, and that they absorb that somehow. Stresses in the home, kids absorb stresses from the parents. You know, if the parents are worried about finances or job security or disrupted routines, or the parents are experiencing, you know, more conflict with each other, that can translate to children. We've heard a lot about, in the news media in particular, about the lack of structure and the lack of routine, right? The American Association of Pediatrics came out and made a statement about the importance for kids to be back in school because what they are losing with respect to routine and structure, and what impact that can have on kids in the long run. So, you know, lack of social contact, you know, FaceTime play dates only go so far. Remote learning is challenging for kids, particularly younger kids, and for older kids to sort of be able to maintain learning environment without getting distracted. And then they miss milestones, right? You know, graduations on Zoom really only simulate the experience to a certain extent, and there are missed opportunities that their kids may sort of carry grief and regret around. Next slide. So that said, you know, sort of at individual levels or at the patient level, the kinds of impact we might see, I wanted to briefly speak to sort of population level trends that we have some information on. So I want to note here that I'll present trends that we have from national surveys. You know, at Sinai, you know, this, obviously we're all adapting and continuing to learn, and you know, we've put in place lots of strategies, including telehealth, including for psychiatry appointments, but we're still culling that data and still understanding the impact. But we do have important trends from national studies that, or surveys that I can point to. Next slide. So I wanted to note why I put the word trends with this asterisk. And that's really because we're still in the thick of it, right? You know, I kind of look at this as almost ongoing complex trauma that we're experiencing as a society, because there are so many factors that are changing and so many factors at play. There's the virus itself, but there's obviously the social distancing, the quarantine, and so on, and stresses associated with that, financial, as I mentioned, worries about the future, changes that it has on our lifestyle, and so on. And it's all happening all at once. And so that complex nature of the trauma is still underway, and we're still gathering the data, still analyzing, and still really understanding what is happening, and we're learning and adapting. So there's all of that, and as of today, right, there's still potential for change and flux in terms of both, you know, how things play out, particularly with school openings around the corner and people kind of figuring out how to handle that, as well as how we continue to respond to this as a society. Next slide. So having said that, and having put that caveat out there, I want to dive in and sort of share trends from 3 different major national surveys that are available to us right now. And so the first one is the CDC National Center for Health Statistics, sort of combined household pulse survey. They began the survey in April of 2020. It's a 20-minute online survey that includes in it, among other questions, the PHQ-2 and the GAD-2. And so the patient health questionnaire for depression screening and the anxiety screener. They assessed symptoms over the past 7 days, and they did it roughly once a week. The sample size varied at each time point, but it was still large amounts of people in each sample. And what they found was that from the beginning of the survey, so starting April 23rd, to the last point at which this slide was created, so early June, if you will, they noticed an uptick in folks reporting symptoms of anxiety. So about 30% in April to about 34%. For depression, they found that from April to July, again, there was an uptick, right? So about 23% in April to about 27% in July. Now, I looked at this yesterday just to see sort of as of today, where does it stand? And they have data through July 21st, and that trend continues to tick upward. Now, it's also notable that when you look at a comparison in 2019, these numbers are significantly different from where we were in 2019, right? So in 2019, we had about an 8% of the population reporting anxiety and about 6% reporting depression. I've included on this slide the link to an interactive dashboard that the CDC has set up where you can go and sort of look at this information on your own. And I do want to note that sort of in my career, this is the first time I've seen the CDC make information like this available so front and center. And I think that in itself is telling in terms of sort of where we see that mental health related to COVID and as resulting from COVID is really a priority. Next slide. So I wanted to share sort of some snapshots from that dashboard that I just mentioned, the CDC dashboard. So this is folks reporting symptoms of anxiety by age. So you can see there is sort of a slight trend up, but you see notable sort of spikes, if you will, or slight upticks beginning in mid-June, which is an important point, and I'll bring this up a bit later as well, because that's really when we started to see some of the resurgence. You also see a sharper increase among older adults compared to other populations. Next slide. I also wanted to include this snapshot, which allows you to break down symptoms of anxiety that are reported by race. So you see again, slight upward trend and notable increases as you go over the course of time in folks that are identified as non-Hispanic Asian, which is an interesting sort of note. Next slide. So you're also able to take the data from the CDC dashboards, export it, and sort of do your own sort of slicing and dicing. So this is a pivot table that I did looking at this data by state. Because I was really curious to see sort of if there is any kind of association to the resurgence that some states sort of specifically saw, right? So you can see here that generally the trend is up. Like if we were to draw a best fit line, it would be sort of an upward trend. But you see a notable increase across the states pretty much around mid-June when the spikes began in Florida, Texas, Arizona, California, and Georgia. And you can see by state as well, you see those regions noting sort of an upward trend around that time. Now, what's missing from this is we don't have pre-COVID information by state on this slide anyway, and we don't have early COVID to look at sort of comparison points, particularly for New York and New Jersey, right? It would be interesting to see, is the higher rate of anxiety in New York just sort of something that's emblematic of New York, or is it, because by April, New York was already at a heightened state of anxiety because of COVID-related worries. Next slide. Similarly, these are snapshots from depression by age. Again, you see that upward trend, particularly among older adults, and right, like overlaying this with what we talked about earlier, with older adults having fears of being high risk, perhaps on their own, as well as sort of the other disruptions to their life. It's sort of a notable increase. Next slide. This is depression symptoms by race and ethnicity. And again, you see that increase in individuals identified as non-Hispanic Asian. Next slide. So the same sort of extract and pivot table for depression symptoms. And again, you see that sort of uptick, a general uptick over the course of time, but a notable sort of increase in the slope of the lines by state around that mid-June case resurgence time period. And, you see it particularly with Arizona and Texas, which is where we saw sort of real rapid increase in cases around that time. Now, again, when I looked at it yesterday, as of the end of July, you continue to see an uptick in Arizona, Texas, Georgia, Florida, and New York in this view. Next slide. I also wanted to share some findings from a Pew Research Center survey. So they did 3 surveys in mid-March, early April, and then late April, and included questions around anxiety and depression, and found that about 1/3 of surveyed adults reported high levels of psychological distress in both the March and in the April surveys. And they found that the distress folks reported was significantly higher, about 55%, if the individual was also experiencing financial distress. Now, they haven't released results as of today. Certainly I haven't found it. And it would be interesting to look at sort of what happens with the uncertainty around financial relief and such on the distress people experience. Next slide. Then the final survey I wanted to sort of include some data around is from the American Psychological Association. So the APA does an annual Stress in America survey, and they updated that to do it monthly to specifically gauge COVID impact. So they did 2 surveys focused on COVID impact in mid-April or late April into May, and then late May into June, with approximately sort of very similar sample sizes. And then they did a 3rd survey in early June, specifically focused on civil unrest, because that was around the time when we were seeing mass protests in response to the murder of George Floyd and really protesting systemic racism. Next slide. So they found in the May survey, the first one, that there was a high level of stress among American parents and higher compared to non-parents. And particularly sort of a source of stress was managing remote and distance learning, which about 70% of surveyed American parents reported. The government response to the crisis was a source of stress for about 7 out of 10 surveyed Americans. And this was really nonpartisan. Across political identification or party identification, folks reported stress about government response. And it was really region agnostic. 70% of surveyed Americans reported stress due to the economy and work. And then stress was significantly higher among Black, Indigenous, and people of color, including, particularly compared with white Americans, around getting coronavirus related to accessing their basic needs and accessing healthcare. Next slide. These sorts of trends hold in their June survey. And there was particularly notable stress reported related to the national reopening, which again parallels with the slide we saw where you see the uptick around the case resurgence. And stress among parents continued to be a theme in their June findings as well. Next slide. 83% in their civil unrest questions reported stress about the future of the nation. This is really striking compared to the previous data from 2018. And about 55% of Black Americans reported stress due to discrimination. And I want to note that in the APA surveys, they found that the levels of financial distress that folks are reporting right now, you have to go back to 2008 financial crisis recession to really find those levels. And it's really different and significantly higher from last year when it was about 40%. Next slide. So again, the stress and the trauma is ongoing. There are multiple sources of stress happening. And then we really don't know sort of, with the resurgence of cases, where folks are opening schools and then having to close them down, we don't know the impact of opening and then having to close down in terms of the toll that it can take on folks psychologically. And there's really no change in the vulnerability of Black, Indigenous, and people of color at this point in time. Next slide. So I want to really quickly just note some strategies for supporting patients. It's important to ask about their distress, including through the vulnerabilities that their racial and ethnic identification or existence even sort of poses for them psychologically, including assessing for heightened risk of suicidality, because we know from prior surveys from the CDC that financial distress can be closely correlated with increased risk for suicide. And I just included some strategies here. I won't go into them in detail for sort of steps that can be taken to support a patient in the office, as well as really through telemedicine. Next slide. I also wanted to include some community resources that are available for free. In particular, I have found the COVID Coach app, which the VA has released for free, to be really helpful. It has some guided meditation and sort of other stress relief techniques that are in there that any patient can sort of practice. And then the National Domestic Violence Hotline as well is one that I want to point out because we have seen an increase in domestic violence over the course of social distancing and quarantine. In fact, in New York State, we saw a 36% increase in March and April. Next slide. So in summary, right, I noted that there are various factors that are associated with emotional reactions to COVID. We see notable trends higher among Black and Brown communities, as well as individuals anticipating financial challenges and parents. But I also want to note that strategies and resources for supporting patients are available. So there is hope. We just have to sort of prioritize it and ensure that taking care of our patients' mental health is part of the treatment plan. Next slide. So here, my email and contact information is here. And if there are sort of folks interested in keeping the conversation going, or if you have other thoughts, suggestions, I'm all ears. And so feel free to reach out. Thank you.
Well, thank you so much to both Ms. Jones and Dr. Iyer. I really feel like you both took us into really the reality of what this pandemic and what this crisis has been, not only for patients, but also for healthcare workers, essential workers, and others. So I really, really appreciated your presentations. I have loads of questions for you, but I see, Helen, do we have a question?
Yes, we have one question from Sonal. Do you think the increase of telemedicine may help address mental health stigmas?
I'll take that one. I think, improving access, Rob talked about this earlier, we heard about in other presentations as well, increasing access through telemedicine is important. And I also think that, being able to see a psychologist or a social worker or a psychiatrist in a safe space without really, some communities, for example, the Asian American community worries about being seen going into a clinic, a psychiatric clinic. And I think those pieces sort of are real gifts from telemedicine to the mental health community, because you can as a patient access care without worrying about the stigmas associated with it. And so I think it can certainly help. It also, I think, helps folks be able to access care when and where they need it. So, if you're working 3 jobs and it's really hard for you to make time to go to an appointment between 9 and 5, the opportunity to reach out to somebody from your home via a telemedicine app at your convenience can go a long way as well in improving access to care.
So I would like to follow up on that, Anita, and can you talk a little bit about what you see around patients actually accessing, if you will, formal care versus informal resources for psychological distress? I mean, that's something we worried about pre-COVID. What are your thoughts about that?
Yeah, I think when it comes to mental health care, the more accessible we make it, and both innovative through technology as well as sort of apps and such, including self-help options, the better it is, right? It helps bring care into a space where it's not something where you have to go into a formal setting, a brick and mortar, get an appointment and access care. I mean, I come from from having run hotlines for several years, and, you see real transformation can happen on a hotline call with a counselor who maybe the first time the patient has spoken to somebody about what they're experiencing, it's not a formal care provider. It's not someone whom they're sort of going to treatment with once a month, but it's whom they needed to talk to in the moment, right as their need arose or right when they were in a state of crisis. And it's the more of those options we make available, and the more we as a health system sort of embrace the need to innovate and to bring care to patients in the ways that they need it, the more we can put care in the hands of people and customize it to meet people's needs rather than making patients fit the needs of the health system.
Mm-hmm. Do you think that there'll be long-term consequences for this psychological distress that we're going? I mean, as Pauline stated, COVID's not going away, but what are your thoughts about that?
Yeah, I think we're only scratching the surface, of what we can expect to see. I mean, the levels of anxiety and depression that folks are reporting is really sort of significantly different from what it was the prior year. I'm also really mindful as a parent myself of young kids. I think about this generation that's growing up in really an unorthodox state in terms of social connections. And what is that going to be like for them? I worry about people who are in domestic violence situations and risk to their lives, and I worry about suicidality. So I think there are long-term impacts of this. And by the way, I just want to note really quickly, there are medical outcomes as well. We know that significantly chronic anxiety and stress and depression impacts folks' ability to access medical care, as well as some of the conditions that sort of Errol talked about at the outset, right? High blood pressure or diabetes, and healthy eating, access to good quality food. I mean, there's so many ways in which, vulnerable populations are going to, I think, see long-term impact.
Pauline, before we go to the questions for our participants, I want to pose almost the same question to you related to what you saw. I mean, I was fascinated by the view into what it took a healthcare system what it took for you to do to prepare, which couldn't have taken you didn't have a year to prepare. You had probably days through, how your staff responded to, all of those aspects. What did you see in terms of the patients? And did you see a change or a transformation or even a reckoning of patients in terms of psychological distress as part of their rehab journey?
So when we speak about the rehab journey and psychological distress, think about it. Prior to COVID, they had visitors, right? In certain cultures, they require their families to be part of their healing. And so when we had no visitors, when we didn't have the iPads initially, we had patients that presented as if they were depressed, right? Because they had no one to reach out to. They knew their families were worried about them, but they couldn't let their families know that they were okay. They heard on the news how many people were dying and dying alone. And so the fear of the unknown continued. And so it was up to us to work with them, to be with them, to reassure them, to implement strategies so that their anxiety could be alleviated.
Thank you. Helen, do we have a question?
Yes, a question from Leisha, and it's for Anita. In addition to an increase in depressive and anxiety symptoms, did you also see an increase in the need for medications to treat those symptoms and needs?
Yeah, it's a good question. That information is not reported in the surveys that I looked at. And I was looking specifically for sort of large scale surveys across the country. But I do know that there have been reports in the news media, for example, of increase in prescriptions for anti-anxiety medications, particularly beginning in February. So that is likely to be correlated. And I think if we dig into prescription data, we will likely find a trend in the upward direction as well.
I have a question for both of you, and it sort of goes back to where we started in terms of Errol's presentation, also Rob's, and a little bit about what we've learned about, populations that you're serving. Can you speak about anything that you noticed? And obviously, you weren't studying this as you were experiencing COVID over these last months, but did you see any shifts that you were surprised about in terms of how various populations participated in care that was available through your various services? And this is realizing that you're both representing somewhat, sort of the specialty end of serving patients. And maybe, Pauline, do you want to go first? And then we'll ask Anita.
Pretty much, again, it goes back to, because we're part of the Montefiore health system, our population is quite diverse. What we found is the family unity was not present due to no visitors. So then there's no statistical studies to support what I'm saying, but what we found is patients needed the support of their family. And it was so evident when it came to COVID. Even to make a decision those that required family intervention, that was not there. And then we had families calling us, and they also needed our support emotionally as well, because again, of the unknown. We had to have physicians do telemedicine for family meetings so that we could reassure the family that we were rendering the best care for their family member, even though they could only see their family member for certain allotted times using the iPads. But also there was some patients that were cognitively impaired. And we still don't know if it was related to COVID, but those patients couldn't participate in the interaction with their families. Sometimes seeing their family members in the iPad was the first time the families were able to see them. And so they had no idea the degree of illness COVID really affected their family members. So it was multifaceted.
Colleen,
And
yeah, I'm sorry to interrupt you. And I'm just struck by how you spoke about the family interaction being so important. I mean, is this something that as a healthcare delivery system, is this a lesson from the pandemic? In other words, you know, did it change the way you and your team and your colleagues viewed patients in your delivery system?
absolutely, absolutely. And we're looking at algorithms to, I mean, we've always included families into the rehabilitation process because we believe if we taught the family, they can continue to work with their loved ones post-discharge to maximize on the rehabilitation, but more so now, more so than ever. Sensory deprivation, what we saw, should never happen again.
Thank you. Anita, could you briefly answer us that question as well? In terms of the patients that you were seeing, were there some aspects of care that maybe differed because of the reasons, you know, well, patients had to find new ways to trust the delivery system?
Yeah, you know, I think I don't have sort of hard data yet, right, in terms of trends and which patients were able to reach us and which weren't, which I really think is an important piece of this because we only know about the patients that were able to connect with us, to Rob's point earlier about the digital divide, right? So we have telemedicine available, but we only know about the impacts on the patients that are able to access those services, right? And, you know, anecdotally though, and largely hearing about it from sort of our care managers and our care management wing, you know, the really key piece that stands out to me is the numbers of patients sort of repeatedly reporting worries about family members and stresses about older relatives that they take care of. And, you know, so how front and center that becomes in a moment like this, that it's not just the patient's own worries, but it's the worries about all of the other aspects of their lives. And, you know, what we think of sort of, you know, we know and appreciate the importance of family in people's lives, but how much that can sort of take up the front of your mind really was something that stood out to me because I would repeatedly hear about that as concerns that care managers would hear when they would call a patient to check in on them.
Mm-hmm. Thank you. Helen, you have a couple of questions, I see.
Yes. Question from Rosemary for Anita. Did you see an increase in patients with the dual diagnosis relapsing? And is there an increase in opioid abuse and substance abuse?
Yeah, and you know, unfortunately, I don't have that detail available just yet. Like I said, we're still in the process of sort of diving into the data. I know I can say for sure that I know that our substance use services, you know, rapidly adapted to being able to support the needs of patients that need to come into a facility, including for opioid treatment regularly, to be able to provide that care to them to the extent possible in innovative ways. But how it impacted adherence and, you know, kind of treatment outcomes or, you know, what have you, I don't have that information just yet, but hope to have that soon to be able to share.
Great, thank you. The next question is from Lori, also for Anita. I'm noticing that the stress related to COVID comes in waves. People feeling like they are handling the quarantining, the social distancing, etc., then getting contacted that they may have been exposed and need testing. Are you seeing this as well? And is the second round of stress, anxiety, and depression worse? And what can be done to handle our responses to these stressors?
That's such a great question, and this is what I was noting earlier, that we still are learning, and this pandemic is still impacting us. We're not really out of the woods, and we're still sort of adapting to it and figuring it out. And I think the question really points to one aspect of it, which is, resurgence of cases or worries about, is it going to come back, new stressors, new worries. And then what happens when you open and then close, or you think things are okay and then they're not. I mean, it takes a toll on you, and it's really different from, sort of, as I mentioned before, a hurricane that comes and goes, and then you can pick up the pieces after. This sustained chronic nature of it is really worrisome. I think one thing we can all do is make it a priority, like I said, to check in with our patients about how they are doing emotionally, and make sure that we're having that conversation so folks have the opportunity to share those concerns, because if we don't ask, we won't know what's going on, and then we miss the opportunity to connect them with resources, because resources are available.
Great, thank you. The next question, not to any panelists in particular, but based on your experience, do you think that the mental health issues with healthcare workers is unrecognized and unaddressed?
Yeah, I'm going to ask Pauline to address that. We do have a presentation on this later on this morning, but Pauline, you did highlight how much you and your colleagues supported one another, and especially your staff during the crisis. Would you take that question? I think you're on mute.
My apologies. We met the staff at the bedside. We rolled our sleeves up. We heard their cries. We gave them support based on what they needed. We educated them. We guided them. Our daily meetings was really for us, right? To communicate to senior leadership. So they heard our cries. They heard the front lines concerns, so they could implement strategies so that at the bedside we were successful. We also had sessions for the staff, right? We had town meetings for the staff because we wanted to know what they needed, what tools they needed, so that we could make their life easier while they were here. Because unlike, as Dr. Io said, it didn't stop. It's not like a hurricane, all right? We had COVID in the hospital. We had COVID out of the hospital, all right? COVID didn't stop. It was continuous. So we had, we met with the staff, minus what we were doing and what could we do to help you.
Thank you, thank you. We have time for 2 quick questions before we have to end the Q&A session. Helen, do you have those questions?
Sure, Dr. Bean. Open question for either panelist. Do you have any recommendations for getting the PTS, PHQ-9?
PHQ-9.
Thank you. Questionnaire filled out as truthfully as possible.
Anita, I'll let you answer that one briefly.
I think it really, it's just an interesting question, I think. And it reminds me of what Errol said right at the outset about patients feeling like they can relate to their care provider or trust their care provider. And I think it behooves us as practitioners and providers to build that trust. The onus is on us, I would say, to build the trust with the patient so the patient feels comfortable sharing with us openly. I would just say, sometimes it helps to have the patient fill it out on their own, and then you can review it with them question by question. Sometimes it's easier to check a box off, honestly, rather than having to confront the feeling and you're sharing it with someone. But I would just say building trust is the job of the provider.
Excellent. And Helen, our last question for today.
Yes. Sure. The last question is from Anonymous. Many of my nursing colleagues are not sleeping, anxious about the second wave, and are carrying a huge emotional burden for patients who died without family. I believe the emotional ramifications for hospital staff has not yet been really addressed. How can the resiliency required for bedside care be supported and repaired?
Pauline, that question is going to go to you, and we do have a talk later on that's going to help us unpack that even more. But Pauline, why don't you take that question?
Work with your staff. Listen to your staff. Be there for your staff. That's the key. It's not easy, but just be there for them and hear what they have to say.
Is your staff expressing concern about the next wave?
Yes, on many levels, but that's why we're learning, lessons learned. We know we have to improve our staffing, all right? Our staffing model, we have to improve. We might not be fortunate enough to redeploy the therapists to the bedside. So what are we going to do in the interim? So we're looking at different staffing models. We're looking at different equipment. We're looking at implementing cameras in each room so that when we make rounding, if they're COVID positive patients, it's not like we have to don and doff the PPEs, but we can look at the cameras. We're putting glass in private room doors so that we can assess our patients from a distance more frequently. So we are implementing different steps.
So it's not just emotional.
Successful.
It's not just emotional support.
The emotional support it's an ongoing, it's a work in progress.
But also it sounds like your healthcare organization responds with true change in terms of making staff feel as safe as possible.
Absolutely. Awesome. Patients are our number one. Our staff is right there with them. Because without effective and strong staff, it can't be done.
Awesome. Well, I want to really express my appreciation to both of you. This has been an amazing, really conversation. As you can see, these topics were really on the top of mind for our participants. And you really took us into the crisis in a way that really helps us focus not only on what happened, but what will happen going forward. So my sincere appreciation to both of you. Thank you so very much. Thank you.
Thank you.
And we'll take our next slide, Latoya, because I think that next slide is going to say that we have a 10-minute break. We do. We are right on time, thanks to all of you. And so we will look forward to seeing you again to start our next session at exactly 10:55 a.m. Thank you all for your participation, your interaction, and we'll see you at 10:55. Thank you.
Hi, Latoya.
Okay, I'd like to welcome everyone back. I hope you had a chance to stretch your legs a little bit. I wanted to now introduce the speakers for our second panel. Dr. Jay Portnoy is an allergist in the section of allergy, asthma, and immunology, and medical director of telemedicine at Children's Mercy Hospital in Kansas City, Missouri, and professor of pediatrics at the University of Missouri, Kansas City School of Medicine. Dr. Portnoy has published numerous articles in peer-reviewed journals involving asthma disease management, environmental control, and mold allergy. More recently, has focused on evidence-based medicine and telemedicine, and was co-chair of the Joint Task Force on Practice Parameters. Today, Dr. Portnoy will present on telemedicine in the era of COVID-19. Next, we'll hear from Dr. Sarah Saja, who is a professor of gerontology and the director of the Center on Aging and Behavioral Research in the Division of Geriatrics and Palliative Medicine at Weill Cornell Medicine. Her research interests include aging and cognition, caregiving, aging and technology, aging and work, training, and functional assessment. Dr. Saja will present on technology and aging adults, opportunities in a pandemic. I'd like to invite Dr. Portnoy to begin.
Great. Thank you so much for that introduction. And I really appreciate the opportunity to speak with this group today. I would have actually preferred to fly to Manhattan and spend some time in New York, but obviously that's not something that's happening in the era of COVID-19. Many things have changed. At any rate, I was asked to talk about telemedicine in the era of COVID-19. Next slide. These are my disclosures. Next slide. And these are my learning objectives. Next slide. So I've given this presentation in many different ways, but one way that I've found to be particularly helpful in organizing it is to talk about the 10 rules for seeing patients by telemedicine. And these are basically things that we've learned over the last few months when we've been seeing patients by telemedicine. After all, our hospital had to switch from in-person visits to telemedicine visits almost overnight. And so it took a lot of doing, but very quickly we learned some of the rules that have been very helpful. So I'm going to go through each of these rules and hopefully you'll find them as helpful as we have. Next slide. So the first rule is figure out what type of telemedicine you want to use. There's, of course, the traditional approach is to do in-person visits. In-person visits is getting in this car and driving from where the patient is located over to where the provider is. That often is in a clinic or a hospital or some other location. That's the traditional in-person visit. For quite a while now, we have done telephone encounters. Every physician talks to their patients occasionally by telephone, but we haven't really counted it as an encounter, mainly because it never got paid for. And if you can't get paid for something, then we tend not to do it. But telephone encounters is very simple. Everybody has a telephone. The patient talks to the provider and they can exchange information. More recently, this direct-to-consumer approach has been used where a patient gets on their computer and the provider is on their computer and they just talk to each other using a video conference, kind of like what we're doing right now, except that it's two ways interactive. That's called direct-to-consumer. The patient could be anywhere. They can be in their home. The provider can be in their clinic or in their home. The key thing is that the patient uses their own equipment to communicate with the provider, and the physical exam is very limited. It's limited to whatever the patient's equipment is able to show the provider. Another approach that has been used is the facilitated telemedicine. In this case, the patient drives to a clinic that is near where they are, and that way they don't have to drive all the way to wherever the provider is. Sometimes that can be quite a distance. So this way they drive to a close place where they use the provider's equipment and digital exam equipment to do a physical exam, and then the encounter is done that way. So that's called a facilitated telemedicine visit. The telephone, direct-to-consumer, and facilitated visits are all synchronous. It means that the provider and the patient are online at the same time. There's also an approach called store and forward or remote patient monitoring, where the patient wears a Fitbit or a pace tracker, something like that, step tracker, something like that, and the information is sent to the provider for subsequent review. or the patient can send a picture of a rash, or they can do a lab test in a nearby facility, and the information is stored in the cloud for review by the provider, and then recommendations can be sent back. So those are asynchronous. That means the provider and the patient are not online at the same time. What you need to do is to decide what kind of telemedicine you want to provide. Next slide. So again, in-person visits is the traditional approach. The telemedicine visits are divided into asynchronous, the store and forward, remote patient monitoring, and then the synchronous visits include telephone appointments, direct-to-consumer, facilitated visits, and we've also been doing inpatient consults using synchronous telemedicine. Next slide. So in terms of the asynchronous and remote patient monitoring, one of the things that have come out recently are these digital inhalers. Digital inhaler is available, it's out, there's now an FDA approved one for albuterol. Inhaled corticosteroids are also coming out. And the nice thing about this is that every time the inhaler is actuated, the information is transmitted to the patient's smartphone or tablet using Bluetooth, and that information can be monitored either by the patient themselves or can be sent to a distant location where a case manager or the provider's office can track how the patient is doing. The thing about this is that the albuterol can be used to monitor as a diagnostic test. It's a proxy for symptoms. The patient using more albuterol, they have more asthma symptoms, so you can tell how well controlled the asthma is. Inhaled corticosteroid monitoring can be used to monitor how adherence to the treatment. If the patient is being adherent, but their symptoms are getting worse, then something is going on and modification is necessary. By combining these two things, we can learn what works to control asthma in the real world. So this can be a very effective way for managing asthma. Next slide. Okay, but the one that I think is most interesting to most of us is the synchronous telemedicine. Again, the facilitated visit occurs when a physical exam is necessary. The patient drives to a nearby clinic where they have digital exam equipment. This is necessary to bill for an initial visit. You have to do a complete physical exam for an initial visit. Certain medical conditions require it. That if you have otitis media, acute asthma, you need to be able to do an exam of the patient for medical purposes. And the key thing here is that it uses the provider's equipment. The direct-to-consumer approach is done when a physical exam is not necessarily required. It uses the patient's equipment. This is done often for urgent care visits. It can be definitive. 80% of the time, an urgent care visit by direct-to-consumer can resolve the problem. But in some cases, it also serves as a triage where the patient is told, no, you really do need to go and be seen in person in an urgent care center. For established patients, a physical exam is not necessarily required, so this can also be done for an established patient. The key thing here is that it uses the patient's equipment, and it is possible to do a cursory exam depending on what equipment the patient has. Next slide. Now, I also mentioned that we're doing inpatient consults with COVID-19 and concerns about that. We don't want our providers and patients to be exposed to each other because there's a risk of infection. So particularly in rural hospitals, a lot of them don't have specialty services. But they have an infrastructure that can accommodate an inpatient consult. So these rural hospitals or urban hospitals that don't have specialty services are looking for them. And so if you're interested in providing services to hospitals that might not have these services, you might contact them and see if they would be interested in having you be on their staff. They would provide the equipment, they would take care of credentialing. Your local hospitals might also be willing to accommodate consults by telemedicine locally. At Children's Mercy Hospital, we don't go over to the hospital to do consults. Instead, we stay in our offices and the patients log into a computer and we see them by video. That way there's no risk of infection. So it's a very effective way of getting the consults done. Next slide. Okay, so rule 1, figure out what kind of telemedicine you want to provide. Rule 2, you need to learn the regulations. One of the regulations is that you need to be licensed in the state where the patient is located. During COVID-19, some of the states have waived this requirement for telemedicine. So if I'm in Kansas and Nebraska may have waived that requirement, so I can see the patient in Nebraska by telemedicine. I can't drive there in person and see them. You still need to be licensed in the state where the patient is located for an in-person visit. For a telemedicine visit, it may not be necessary due to these waivers. The waivers are expiring over time, and so it's important to check with each state that the patient is located in regularly to make sure that the waivers are still in place. In addition, CPT codes are available for new patients, and most of them, the CPT codes require that a full physical exam be done. For an established patient, you only need 2 of 3 components: history, physical exam, decision-making. For a new patient, you need all 3 of them. During COVID-19, those requirements have been relaxed, so you only have to document the parts of the physical exam that you were able to do by telemedicine if you're doing direct-to-consumer. And if that was sufficient to make the diagnosis, the CPT codes will allow that right now during COVID-19. It's not clear how long that will continue. Also, HIPAA regulations were relaxed. It permits providers to use their own personal device to see patients. Before that, if your device wasn't specifically approved as being HIPAA compliant, you weren't supposed to use it, but now there's some relaxation. It doesn't mean you should be casual about personal health information, but it means that you can at least use reasonable precautions. And then the requirement that a physician must have an established relationship has been waived. So you can see a new or established patient by telemedicine, either or by telephone, and these are now billable services. Next slide. So one of the limitations to seeing patients across the country by telemedicine is the fact that you have to be licensed in all of these different states. There's 51 different states, and who has the time and interest in getting licensed in all of these? So there's this interstate medical license compact that has formed, and basically it uses the driver's license model of medical licensure. If you're licensed to practice in Kansas and you see a patient by telemedicine, you're allowed to see patients by telemedicine in any of the other states that are members of the license. Sort of like the driver's license. If I have a driver's license in Kansas, I can drive in Arkansas without getting an Arkansas license. My license is good for all of the states in the country. And the same thing with telemedicine. Your license to practice medicine is good in all of the states that are members of this compact. And the states are continuously entering into them, so more and more are becoming members of it. It's helpful to keep track of that. Next slide. I mentioned that these rules change every day. So this is the Federation of State Medical Boards, and every day they update this. It's important to go to this website if you're going to see patients in a state where you're not licensed to see what the current regulations are. They literally change every day, so it's a good idea to check on this at the beginning of the day if you're going to see somebody in a state that that you're not licensed in, just to make sure that the rules haven't changed. Next slide. Okay, so once you know what the regulations are, it's important to select a platform for seeing the patients. This is Rule 3. If you're going to do two-way video, that's where the patient and provider can see and hear each other in real time. It's very important to do that if you're going to do direct-to-consumer or facilitated visits. It also helps if the platform allows for multi-presence. Sometimes as an attending physician, I have a fellow who also wants to participate in the care, and then there's the 2 parents. One parent might be at work, another parent might be at home. And so it helps if multiple people can join in, because then you can all participate in the encounter. Mobile apps ideally should be available so that people can log in using their smartphone or tablet device. It also helps if the platform allows for screen sharing. That way you can show the patients the results of their x-ray. You can show them lab results. You can go over instructions and show it to them on their screen. If you're going to do a physical exam using digital exam equipment, then the transmission of that information needs to be possible if you want to do that. Not all platforms allow for transmission of digital exam information, so you should check on that before you select the platform. Some platforms are integrated into electronic medical records. This can be very helpful. That way, the scheduling module of your electronic medical record can be used to schedule a telemedicine visit. If you're using a standalone platform, then your scheduling has to be synchronized between that platform and the electronic medical record. So that requires a lot more work. So integrated environments can be very helpful. And finally, it's important that the platform be HIPAA compliant at least as much as possible. And that means that, that the information is transmitted peer-to-peer rather than going through a server, intermediate server, and then being retransmitted, because if it's stored on a server, that information can then be hacked and read by other people. So you just have to make sure that the information is secure when it's transmitted. Next slide. Once you've selected the platform, then it's time to build the infrastructure. The infrastructure needs to have a good internet connection. It's reliable with low latency. And then you need to have appropriate equipment. If you have an embedded in the EHR, in the electronic health record, that's very convenient because there's a window and then you can see the patient's medical record at the same time. If you have a separate medical record and a platform for telemedicine, it really helps to have a double monitor so that you can have the telemedicine on one monitor and the health record on the other monitor. Or it's possible to use an iPad with a monitor or a smartphone or something like that. If you're going to do a facilitated visit, you need to have the digital exam equipment available as well. It's also helpful to have a professional looking background. You can have a green screen and put in a professional looking background if you want to, but it's good to have the background look like a medical facility or at least some professional thing. Next slide. So now you've chosen the platform, you've decided what type of telemedicine you're going to do, you know the regulations, you've got all of the information ready to go. It's time to schedule appointments. In this case, when you schedule an appointment with a patient, you have to determine whether, if they're going to do direct to consumer and use their equipment, they need to have an internet connection. They need to have a computer or a tablet or a smartphone, some method of using a video conference. We determine that when we schedule the appointment. If they don't have that ability, then they can't have a direct to consumer visit. We send the appointment invite by email with a link to the system. It's sort of like what you got today to join this conference. We don't send any personal health information in the email. We just say that here's a link to your visit, and we don't disclose any other information. It's good to send instructions in advance. We do pre-registration online. We send them a link. Patients can log in and fill out review of systems and family history and sign consent forms and do all of that stuff. Also, if there's an app that's needed to run the platform, we ask them to download the app prior to the visit so it's ready to go. We give them a website or phone number to call if they need assistance. Sometimes they're having trouble getting logged in. They need to have a way of contacting somebody to get help if they're having difficulty logging in. And we ask them to take this seriously. This is really a medical visit. So if they aren't going to show up, if they can't do it, they need to cancel or reschedule the same way that they would with an in-person visit. So we ask them to keep that in mind. Next slide. These are the instructions we send to patients when we schedule an appointment. We ask them to be present during the visit. It sounds pretty obvious, but if it's a child, a lot of times the parent will log in and the child won't be there. You're doing it by video in part so you can lay eyes on the child and see what they look like. If there's a rash, you can look at the rash, but at the very least you want to be able to look at the child. We ask them to log in 10 minutes before the visit to make sure that their equipment works. We ask that they locate themselves in a quiet and private place. They shouldn't be out in the lobby of a hotel or something like that where there's no privacy and it's very noisy. We ask them to keep the video on during the visit. I like to see the person that I'm talking to. It just improves the quality of the encounter. Ask them not to multitask. Don't do other things during the visit. Don't be cooking your meal while you're trying to do a doctor's appointment. During the visit, you should focus on the actual visit itself. And again, you want to make sure that they have a phone number to call if they have problems. Next slide. Get informed consent. This is required. You need to get consent whenever you see a patient by telemedicine. Tell them what it is, what the benefits are, the risks associated with it, and that their information is secure. In general, this is valid for 1 year. And if you need examples of a consent forms, the teleresourcescenter.org has examples. Next slide. You prepare for the visit pretty much the same way you would for an in-person visit, reviewing all of their records before they occur, and encourage the patients to sign up for the patient portal in advance. Next slide. Then you see the patient. When I see a patient, I always start out by asking if they can hear and see me. I tell them where I'm located and I verify where they're located. They need to be in a state where I'm licensed to practice. Otherwise, we're going to have to postpone the visit. You want to look into the camera when talking to the patient. If you have to look away for some reason, explain to them what you're looking at because it can be very disorienting. You can review labs or other documents by showing your screen. And keep in mind, most telemedicine visits are actually shorter than in-person visits. They tend to be focused, more goal-oriented, less chit-chat. And the patients are really okay with this. They just talk less. They're more interested in getting their problem resolved. Next slide. We've done satisfaction surveys patients with telemedicine, and for the most part, patients are very satisfied with telemedicine as a platform. Next slide. As a matter of fact, 2/3 of the patients are as satisfied with telemedicine as they are with in-person visits. 1/3 of them are actually more satisfied with telemedicine than in-person visits, and very few patients prefer in-person visits over telemedicine, which is just the opposite of what a lot of providers think. The patients cite convenience, they're curious about the telemedicine, they like the technology, they've had a positive experience. The only reason that patients tend to not like telemedicine is if there have been technical issues. Next slide. To do a physical exam for a facilitated visit, you can train the facilitator to use the equipment, tell them what part of the exam you want them to do. If they need to do palpation or measure range of motion of limbs or things like that, you need to train them to do it. The provider can observe that being done and use that as part of their exam. For direct-to-consumer visits, you can ask the patients to show you a rash if their equipment allows it, and you can document whatever parts of the exam you can observe. Next slide. So this is what, there's a lot of digital exam equipment available. There's otoscopes and stethoscopes. You really can do a physical exam using telemedicine. Next slide. And if you're doing direct-to-consumer, this is an example of things you can observe just using a tablet or an iPhone without digital exam equipment. So you can document a physical exam if you need to. Next slide. The last rule is to bill for the encounter. The reason that telemedicine hasn't gone on as much as it could have is because we couldn't get paid for it. A lot of states now have laws that specifically cover telemedicine services. Most of them now require that if you cover a service by in-person, that it needs to also be covered by telemedicine. That's coverage parity. What we're also looking for is reimbursement parity, that they pay the same amount for a telemedicine visit as for an in-person visit. If your state is in the process of developing these bills, you might consider contacting your legislators, your state legislators, and having some input into this, because a lot of them are looking for advice on how to write these telemedicine bills. Next slide. There are CPT codes available that can be used for billing for telemedicine services. Telephone services and online digital examination and management services are billed by time, so you have to record how much time you spent. You can also bill for remote patient monitoring. Next slide. If you're going to, there's also these G codes that are used for viewing videos that the patients might send to you. So these can be used also. Next time. And then if you're doing a face-to-face visit, the E&M codes are exactly the same as you would with an in-person visit. The only difference is you'd use a G modifier. And if you use that, that tells the health plan that it's a telemedicine visit. It should be reimbursed exactly the same as an in-person visit. Next slide. So with that, I'm going to end. I'm hoping that I'm on time. I hope that you enjoy telemedicine and that you stay safe. Remember, the only infection you can get when you're seeing patients by telemedicine is a computer virus. It's very safe. This, by the way, is my new look. I've got these beautiful goggles here. They're very stylish and fashionable. And then I wear my mask like this, and it's my new look, and it's the way we're all looking now, but it works, and we're all trying to be safe. And hopefully this COVID-19 thing will end soon. So thank you again for inviting me to participate in this conference, and stay well.
Hi, I'd like to thank you also for inviting me to participate in this conference. And I'm going to be highlighting some of the other pitfalls of the pandemic for aging adults and their families, and talk about some opportunities from a technology perspective. Next slide. So my overall goal is to really demonstrate how we're using technology applications to help remediate problems with social isolation and access to resources among both aging adults and informal caregivers. I do have one financial disclosure, but I'm not including any references to iFunction. Next slide. So we're going to click through. So I'll talk a bit about some of the challenges associated with the pandemic for aging adults and formal caregivers, talk about how technology might be used to meet these challenges. And then what I'd like to do is highlight some of our research that we're doing at our new Center on Aging and Behavioral Research. If we have time, quickly run through 3 projects. We've adapted all of these projects for the pandemic, and then finally highlight some important next steps in this research space. Next slide. So just a little background, since we're new, the Center on Aging and Behavioral Research, I direct it, and we're really about conducting research to understand factors and contextual issues that foster successful aging. And we all know that successful aging has not one definition, but it's a multi-dimensional construct. We also want to try and find efficacious strategies to enhance the quality of life for not only the older adults, but also for their families, because it has been stated throughout this conference so far, the central role that families play in caring for each other, particularly in caring for older adults. We also, of course, want to provide training opportunities for students and junior faculty. Most of our research, I would say, is done in the community. So community collaborations and collaborations with older adults within the community is extremely important to us, as are collaborations with other researchers. Next slide. I'll just show you where we sit. We're in the Division of Medicine, particularly Department of Medicine, particularly Division of Geriatrics and Palliative Care, which has 3 legs to it, if you will, clinical, research, and education, and we sit in the research space. Next slide. So what are some of the challenges that we've thought about with respect to the COVID-19 pandemic? Next. And I think what we've been focusing on is what are some of the special challenges for aging adults and their families. And again, I'm going to be speaking from a behavioral perspective. Next slide. Next, okay. So I think the stay-at-home and pause requirements, what we've thought about is how it's really drastically diminished older adults' opportunities for not only social engagement, but also cognitive and physical engagement. It's limited their access to routine medical care, as we've been hearing about it, and as our prior speaker just focused on. Also social support networks and structural support, such as group meals and community centers, community activities. At the same time, it it's had an impact on caregivers, and it's really limited informal caregivers who play such a central role in caring for older adults, their access to resources and support. And I think overall, and this is, I think, is going to be, and it's starting to be highlighted now, one of the big pitfalls or another consequence of the pandemic, besides the health issues, are increased problems with social isolation and loneliness. Next slide. So let's just start with some definitions, because these terms often get confused. Loneliness is subjective. It's a feeling that someone has that their social relationships are not up to par, that they're deficient. In contrast to that, isolation is an objective space, and it arises in situations like the pandemic, where a person may have limited opportunities to interact with other people. Social network, of course, is an interconnected web of relationships. And social engagement is another term that's used in this space, and that talks about the degree of someone's participation in community or society. And we can think about three levels: personal with family and friends, a neighborhood, like with the senior center, and then societal in terms of contributions that they make overall or to social causes. Something to recognize, of course, is that loneliness and social isolation, sometimes they're lumped together as one, and in fact they are distinct. A person can, for example, live alone and not feel lonely, or be isolated and not feel lonely. And a person can have a very large social network and still experience loneliness, because loneliness focuses on quality of relationship. Next slide. So social isolation and loneliness is prevalent among older adults, and this is some pre-COVID data from AARP that gives estimates about the percentage of older adults, this is in the United States, who suffer from loneliness and who are isolated. It's a fairly large percentage of people. Next slide. And people who are especially at risk for being isolated and experiencing problems with loneliness are the oldest old. These are people traditionally defined as people 85 and older. Those with disabilities, something we think about a lot besides mobility impairments is hearing impairments, because as you know, people who experience a hearing impairment often withdraw socially because they don't feel they can actively participate in an interaction. Those who live alone or in assisted or skilled nursing facilities of lower SES status, and of course, informal caregivers. Next slide. The impact of social isolation and loneliness has been well researched, and there is very solid evidence here that in addition to providing lack of access to services, resources, and support, it's also associated with poor physical, cognitive, and emotional health status, and an increased risk for mortality. In fact, one of our prior panel members spoke about the increase in emotional distress, such as anxiety and depression among aging adults. And this may certainly be due to concerns about their enhanced vulnerability to the COVID infection, but also perhaps to their disruption in social relationships and social networks. Next slide. So how can technology help? Well, certainly it offers the potential of increasing social support and connectivity. And I just want to make an important caveat here. We don't think that technology replaces human contact. We really think of it as something that can augment human contact. As we can see with telemedicine application, it can augment interactions between physicians and patients, or providers and patients. We can get lots of access to information and services through things like the internet. And there are also increased opportunities for social interaction and support through applications like Facebook, Zoom, email, and even social robots. There's now a lot going on in the social robot space in terms of providing social support for aging adults. Next slide. And if we look, we do see an increase. This is some data from the Pew, and the even more recent data shows the same thing, where we are seeing percentage of older adults using the internet and using things like smart home is on the rise. But we still have, and this has been talked about earlier, and I'm going to come back to this later, a digital divide, especially among people in the oldest old group, those of lower socioeconomic status, minorities, and those with disabilities. If this is some data from 2018, and we can see that while the difference in smart home ownership, while this has ticked up a little bit in the over age 65 group, it still is considerably lower among that age group compared to other age groups. Next slide. So I want to just highlight a couple of projects that we're doing at Weill Cornell in our center. The first is I also direct an NIH-funded center called CREATE that focuses on older adults and their interactions with technology. It involves University of Illinois at Urbana-Champaign, University of Miami, where I was until recently, and Florida State University. Anyways, we developed a software system called PRISM, and we designed this system specifically for older adults, and we involved older adults in the design of the system. It's a whole system. It has the software plus technical and structural support. And using the PRISM system, which we placed on when we did this first trial on PCs, people could have easy access to email, internet. We had a classroom feature, a calendar feature, games, a feature where they could access community information. That's what the homepage looked like. And we evaluated PRISM in a cross-site randomized control trial that was cross-site, included a control group among 300 older adults who ranged in age from 65 to 98 years of age, which is significant. I believe 30% of our sample was over the age of 80. And these folks had never used a computer before and had no technology in their home, no computer technology, no internet, and they lived alone. So we purposely selected this sample because we felt they were at risk for social isolation, and PRISM might be able to help them. Next slide. So our aims were to really find out, is PRISM useful? Is it usable? Our primary outcomes were related to social isolation, support, and well-being. We also wanted to gather information if people use this system, with their attitudes towards technology, their self-efficacy about using technology change, with their general adoption of technology change. We looked at this longitudinally. People had the system from a year. We put it in their homes and trained them individually over 3 days. And then we wanted to see which patterns were most useful. Next slide. So some of our findings, and this is published in the Gerontologist. Here's our sample. One thing that we're very excited about, given who was selected to participate, were that we were successfully able to train everyone on the use of PRISM. Okay, there wasn't one person, even those in the oldest old cohorts, who are not able to learn to use PRISM. These were some of the reported benefits that we collected, qualitative as well as quantitative data. They really liked being able to communicate with family members. At that time, it was via email, finding information, playing games, and they continued to use the system. We had sustainability throughout 12 months, the 12-month period, for about 4 days a week. Next slide. We also found changes in our primary outcomes in the expected direction in terms of increases in perceived social support, decreases in perceived loneliness, well-being, and also on our secondary outcome measures. Next slide. So where we are now is we are in the middle of evaluating a brand new Prism, Prism 2.0. Again, it's an enhanced version of Prism. The homepage looks different. That's a shot of it on the bottom of the screens. We've increased the features for socialization. We've added a health feature. It's available now in English and Spanish, and we're looking at it in diverse contexts. In Prism 1.0, everyone lived in the community. Here we're looking at the efficacy of PRISM in rural locations with seniors who live in rural locations at FSU. Illinois is looking at senior housing. Miami, we're looking at folks in assisted living. And we got a supplement at Weill Cornell Medicine to look at people in urban locations, particularly those with MCI. Next slide. So these are what some of the screens of PRISM look like. You can see it's very, very easy to use. For example, in games, if you want to play single or multiplayer, you just simply click on whichever you want to do. We have educational information, email, health information. So there's a variety of things one can do with the PRISM system. And we actually collect data on use of the system. What do people use? How long do they use it? How often do they use it, etc. And there is a control group, of course. And we've upped the ante here because our control group here is that PRISM is now on a tablet instead of a standalone PC. People in the control group get a standard tablet. However, we're not putting the PRISM system on the tablet. Next slide. So here's a study that we're actively recruiting for now, and this is PRISM MCI. We got a supplement from the NIH to see if the system, and we've pared down the features somewhat to make it even simpler to use. Would it be valuable for people with mild cognitive impairment? And I just want to comment a couple of things about this. We just have approval now. We're going to be doing the whole study virtually. We're going to train people virtually, enroll people virtually, consent people virtually. We have a whole protocol for doing that. And since the COVID pandemic, we now have 30 people. This is a small pilot with our MCI participants, 30 people who have contacted us who want the system. And something I think that really took us by surprise was that we initially did not have Zoom on PRISM. But our participants asked us if we could put Zoom on the system for them so that they could interact with their families. We've done so. We've also developed a training protocol so we can train them remotely on how to use Zoom. So the way this is working is we load everything on their tablets, we mail them to it, we use something called TeamViewer to train them. I don't have data yet because we just got IRB approval and we're just going to start our virtual protocol with a few people this week. Next slide. So here's just some, I always like to show a few quotes. These are some of the quotes from our early MCI participants to show you how they're using PRISM and why they like it, because they can be in touch with their family and friends, they can play games, they can do lots of different things with PRISM. Next slide. Another study we're doing is the Care Partners program, and this is focused on family caregivers of people with early stage dementia. Again, it's a technology-based program, and next bullet, please. And it's delivered at home. It's a dyadic intervention, so there's a component for the caregiver, the patient, a joint component for both the caregiver and the patient where they interact together. It's on a tablet, and by the way, in all of our studies, we provide our participants with the technology and with internet access. These are some of the features that are on the system. There's support groups for the caregivers that we do using video conferencing, cognitive training for our patients. We have pleasant event videos where we actually have virtual tours of the Rubin Art Museum, of the Botanical Gardens, of the Intrepid. We now have poetry videos on there so people can not focus so much on the disease, but on other things outside of the disease, lots of access to information, etc. Next slide. This is what the screen looks like. Again, you can see some similarities with PRISM. We actually involve both caregivers as well as early AD patients in the design of this system. Next slide. So some of the intervention or innovative features is that it is dietic. We're including both members of the dyad in the intervention. Next. It's delivered in the whole intervention is delivered in the home using computer laptops. And again, since the pandemic, we're going to now be we used to do everything, the initial installation and the baseline assessment in the home. Since the pandemic, everything will be done virtually. So our research assistants will not go to the home. The caregivers nor the patients have to visit us at Weill Cornell. We've adapted our whole protocol to accommodate this. As I said, we provide internet. People keep the technology at the end of the study. We don't take it away. Next bullet. We're focusing on early stage of the caregiving trajectory, which often has not been the focus of prior caregiver interventions. Next slide. And we're looking at a non-pharmacological treatment approach. Next slide. Also, I just want to point out that it's being evaluated with diverse ethnic populations, especially those in across all of the boroughs of New York City. We're even in New Jersey, and the intervention is available in both English and Spanish. Next slide. We can skip this. Next slide. And a final study I want to highlight is our FIDDLE study. This is focusing on providing a technology-based intervention that this is geared for sedentary older adults, and it has both a physical and social component. People join the program. We give them prescribed physical exercises. They are in teams, so there is a social engagement component. They can virtually interact with their teams. They have their exercises are prescribed every week. They have goals. They build up in their library. They receive motivational feedback. And again, this is a home-based program. Everything is done in the home. And we have now, in fact, we're starting this week, adapted the whole program so it's virtual. Folks used to come into the lab for training. We're now doing the whole training virtually. And since the pandemic, we have now, I think, in New York, we're doing this in New York and Miami. We have a request from 36 more people who are waiting to be trained and join the program. And I'm very pleased that even though we can't do our research face-to-face as we used to, because of the nature of our research, that it involves technology, that we've been able to adapt our protocols, and we're seeing big interest among seniors in the community to be involved. I think they perceive it as a way not only to learn something new and stay connected, but also to stay connected and be engaged. Next slide. Next slide. So in summary, I think technology holds a lot of promise in terms of enhancing social connectivity and support for older adults. However, you can go through these quickly. A stronger evidence base is warranted on the effectiveness of these types of interventions. And it's very important to include diverse samples of older adults. And I just don't mean in terms of culture and racial diversity, but also in terms of socioeconomic status, in terms of disability status. I think we have to think long and hard about privacy, about how to best train people to use these kinds of technologies, and think about also are there some potential negative impacts. Is social interaction being impacted in a negative way if people are online all day? And this has been alluded to earlier in several presentations. We really want to think about meaningful access. And this goes beyond just giving someone the technology. We really have to make sure that it meets their needs, their preferences, and that they're able to use it. And certainly there are a lot of policy implications around ensuring access. Next slide. And so I think some barriers for adoption right now are lack of knowledge and awareness of these technologies and what they can do. Okay, you can click through these. Lack of training and technical support. Cost is still an issue for many people. Cost of monthly internet, cost of the technology. For a lot of systems, there's what we call feature creep. These systems are becoming increasingly complex to use. Think about the iPhone. It's really hardly thought of as a phone anymore. There's so many other things that it's intended for. Usability, I believe, is a huge barrier, and technology by nature continues to change. So people constantly have to learn new versions of software, be aware of new versions of software. And I think this can really have a negative impact on technology adoption. Okay, next slide. So this is how people are, we're still recruiting, as I've alluded to. Here's a number where you can reach us. If you know anyone who wishes to be involved in our research, next slide. And here's my contact information, should you want to get hold of me. Thank you very much.
Thanks so much, Dr. Saja, and thank you, Dr. Portnoy. Helen, what questions do we have for the two presenters?
Yes, the first question is from Malinka, and she wants to know, is Prison 2.0 available?
It's available right now, yes, in a research capacity. In fact, we're hoping that we're going to make it available commercially very soon. We have some conversations coming up with our technology transfer office at Weill Cornell, but we are recruiting for our research projects, so it is available from that perspective.
Great, thank you. This next question was asked more than once. Does your program help patients obtain a computer?
Pardon me?
Does your program help the patient obtain a computer?
Our program, actually, in all of our studies, we provide the computer to the patients, and then they are able to keep the technology when the research is over. And for example, and then we help them transition. When our program's not available, we show them similar programs. We teach them how to use the internet, the general internet. So we have a whole protocol for doing that.
Great, thank you. The next question is from Gay, and she wants to know, what are the challenges related to telehealth services in rural communities, and are you anticipating Medicare and Medicaid reimbursement issues given the economic stress from COVID?
I think that a lot of the health plans have learned from the COVID experience that telehealth can be a solution rather than a problem. Delivering healthcare to rural communities has always been an issue, and telemedicine is a particularly good solution for that because most rural communities have a lack of specialty services and medical care in general. So I'm anticipating that the telemedicine will probably continue to be an important aspect of care delivery in rural communities after COVID is over. As a matter of fact, our hospital, which is not in a rural community, let's see, I'm not muted, am I? Oh, you can hear me, okay. Our hospital, which is not in a rural community, has decided that it wants to target at least 40% of our outpatient visits to continue to be done by telemedicine, simply because it's what the patients need. It's more efficient. It frees up the space here in our clinic so we can do procedures that require an in-person visit and have the patients for routine follow-up appointments be seen at home. It saves on the overhead. It's just a more efficient way of delivering care. One other thing, I noticed somebody asked a question about whether insurance companies benefit from telemedicine. They absolutely do. And in fact, most health plans actually encourage their subscribers, their subscribers to use direct-to-consumer for urgent care visits. And if you have an employer-provided health plan, your health plan probably offers that as a subsidized service, website where you can log in and see an urgent care doctor if you have a question to serve as triage. In most cases, the problem can be resolved with that visit alone, but it can certainly reduce the number of urgent care and emergency visits, which health plans are very much in favor of.
Yes, thank you. We have another question. This is from Mark, and he wants you to please clarify what type of interactions are considered online digital E&M services.
Online digital services. I mean, I guess synchronized visits would be direct to consumer and facilitated telemedicine. So those would be, those would be telemedicine services that can be reimbursed at the same rate as an in-person visit. There are also telephone visits. They are reimbursed based on time spent. But again, that can also be done now. I'm not sure what else you wanted to know.
Okay, thank you. The next question is from Liz, and she wants to know, do you work with the public libraries? This is for Sarah, I'm sorry. Do you work with the public libraries providing access to electronic library cards and catalogs?
I think that's for me. We haven't done that specifically, but we do point to public libraries in our resource guide as a resource for older adults. And I will say that we also you interact with the public libraries to recruit seniors in our projects. And we do a couple of projects, I didn't mention them here, where we actually train folks at the library. We use the library as a facility to train people and enable them to interact in our programs. So it's a great, I think, underutilized resource in the community.
Great, thank you. That was it for the questions in the Q&A and chat boxes.
Great, we have a few more minutes. I actually have a couple of questions. One for Dr. Portnoy. I was curious, in the patient satisfaction data that you have, certainly that's the folks who actually answered that was sort of a self-selected group because they engaged in the service. Did you look at attitudes about telemedicine sort of in the population overall, including those who had not yet engaged in those activities?
Well, I mean, we do satisfaction surveys of patients who are seen in person, but we can't really ask them about their experience with telemedicine unless they've actually done telemedicine. Otherwise, they don't have any basis to have an opinion. We haven't asked them whether they would like to do telemedicine if they haven't already done it. So I guess in that respect, we haven't done that. The patients who responded whether they preferred telemedicine or in person, for the most part, were patients who had done both types of visits, and then they had some way of comparing the two. And those patients either thought that they were equal, 2/3 of them, or 1/3 of them preferred telemedicine over in-person visits. And if you do telemedicine and you talk to the patients, they really like it. I always ask them at the end of the visit, well, what do you think about this visit? And for the most part, they're very pleased. It's very convenient. It's different. They're a little bit puzzled sometimes, but they really like it. And their problem gets resolved. And they didn't have to drive in and be seen in person. So I think as people become more and more experienced with this, they're going to start selecting it. Just be prepared.
Great. And did you see in either in your just anecdotally or in those satisfaction data, any differences based on age or language or other factors?
We didn't look at that, but I've reviewed a couple of papers that are now in press that will be published soon. There's several of them that evaluated telemedicine satisfaction during the age of COVID-19. And they basically, I'm trying to remember what they found. There was a relationship between, I can't remember the details. That information will be available, but I haven't noticed any particular difference.
Okay, great. Helen, any more questions have come in or?
Yes, we have some more questions coming in. This is from Rosemary to Dr. Portnoy. How are you dealing with the digital divide in your patient population, or are you experiencing that? And secondly, do you resort to telephone visits instead of virtual?
It's been an issue with some of our patients, particularly inner city, low income families where they don't have access to the internet. Also, I've had a few patients in rural communities that didn't have it either. They had to get in their car and drive somewhere near a library where they could connect to the internet in order to do their visits. So I've actually seen patients in their car because that's a limitation that they have. So the digital divide is real, and it's something that's going to need to be addressed if we're going to start doing more telemedicine. In terms of liability, because I saw there was a question about liability, there really hasn't been any increased liability when telemedicine is used versus in-person visits. It doesn't seem to increase the risk of malpractice or anything like that, at least not so far.
Great, thank you. Our next question is from Marlon, and he wants to know, how do you deal with patients that have poor health literacy and cannot give you the clinical information you need in order to evaluate them in a telehealth visit?
An issue also, our patients, we do have patients who literally cannot turn their computer on and they just don't know how to get connected. And when that happens, we can revert back to a telephone visit. We will see them however we can see them. And if they need to just call on their telephone and talk to me that way, then I'm happy to do that. We can't bill the same way. Reimbursement isn't the same, but I'm in the business of seeing patients, and that doesn't concern me so much. We make an effort to do the video conference. If it doesn't work out, we will refer back to just a telephone appointment.
Great, thank you. We have a question from Mark to Dr. Portnoy. How do you overcome the technical challenges for some patients? Is there a limit to what E&M codes can be used since physical exams cannot be done? And should we record the visit as a medical record?
Well, in terms of record, you mean document it the way you would a regular medical visit? Absolutely. We always document it. We document how much time we spent on the visit. We document where the patient was located, where I was located. We document that they gave informed consent. We also document who was participating in the encounter. So the documentation is exactly the same with additional information about the telemedicine component of it. In terms of E&M codes to be used if you can't do a physical exam, right now you can use a regular E&M code for a new patient or a follow-up visit, even if the physical exam isn't complete, because there have been waivers. There's some leniency there. Once COVID-19 is over and the waivers go away, the CPT codes for a new visit, an initial visit, require that you do a complete physical exam, including 10 systems. You can do that using the template that I showed on the one slide, where you can just look at the patient and document in general, but technically speaking, you'd need to use digital exam equipment to do 10 systems for an initial visit. A follow-up visit does not require a physical exam. It never has. So you can do a follow-up visit without physically examining the patient. And that's done all of the time, and you can still bill for it.
Thank you.
Ellen, any other questions from the Q&A box?
No, there isn't.
Okay, we have 5 minutes left. Dr. Sasha, I'm very curious, I have to admit, about social robots. Would you mind just saying a few words about that and what the evidence is and what people's experience are?
I think the one you're most familiar with is the one that looks like a little lamb or the little white one. I forget the name at the top of my head. The research here is very exploratory. It's not something we're doing at Weill Cornell. I don't really know how I feel about them. I think that they may have their place, I think, more in terms of perhaps providing assistance with more ADL, IADL activities and maybe incorporating a little socialization there. But I think they would have to be implemented very carefully. And I do not think that they can take the place of a human interaction where people actually are interacting with another human, even if it's virtual.
Brave new world. Thank you.
Yes.
I did have one additional question for you, actually. You mentioned that you took a look at, with regards to the outcomes from the Care Partners program along, I think, language maybe and ethnic lines. Did you look at all at subgroups when you studied the PRISM program? Did you see anything shake out as far as differences along language or ethnicity or other social variables?
In PRISM 1, we only did English because it was our first time through with that. In PRISM 2, we will look at differences according to ethnicity and culture. We do find, however, I just saw some very early data for PRISM 2 yesterday that said that age and education is a predictor of use, and that's not surprising. But we found that, some of our older people tend to use it less because of health reasons, because especially in the skilled nursing facility, we've run into problems where we've lost people because they've died, and that's being done in Florida, and assisted living. And in Florida, assisted living to a large extent is like skilled nursing. So it's not the people are really not as independent as one might think. But we're still able to teach them to use the system, which I think is really encouraging.
Great, thanks so much. I don't see any other questions. And if that's the case, thank you again for your presentations. Those were very informative. And I'll turn it back over to Susan for the next panel.
Right. Stay safe.
Thank you very much. Really learning so much today. And Jonathan, thank you for asking that question about the social robots. And Sarah, thank you for endorsing human beings. All much appreciated. So our final panel for this conference will consist of the following two faculty. Mark Knapp serves as Senior Vice President for Medical Affairs and Deputy Chief Medical Officer of the Mount Sinai Health System, overseeing medical staff operations for the 8-hospital system. He's involved in managing healthcare quality, regulatory compliance, medical legal affairs, physician leadership development, and emergency management. Today, Dr. Knapp will present on national organizing of volunteers and resources. And then we will hear from Jonathan Ripp, who is Professor of Medicine, Medical Education, and Geriatrics and Palliative Medicine, and Senior Associate Dean for, this is my favorite, Well-Being and Resilience. He is the Chief Wellness Officer at the Icahn School of Medicine at Mount Sinai. In the role of Chief Wellness Officer, Dr. Ripp oversees efforts to assess and provide direction for system and individual level interventions, which are designed to improve well-being for all students, residents, fellows, and faculty in the Mount Sinai Health System. He will speak on healthcare workforce well-being in the wake of COVID-19, the Mount Sinai experience. So Mark, will you begin?
Thanks very much, Dr. Bean. Latoya, am I going to have control? Okay, here we go. So my objectives are aimed at trying to help the participants understand what it was like to manage COVID-19 pandemic from a hospital perspective and hospital workforce perspective, the challenges that were encountered, what we had to do about stretching our resources, and what we had to do in the event that we actually had run out of resources. And I'll give one example of that. I have no financial disclosures. First off, let's get into planning and reacting. Here you see a picture on the very first day that we activated our Emergency Operations Center at Mount Sinai. Mount Sinai, for those of you who don't know, is an 8-hospital system. Flagship hospital is the Mount Sinai Hospital on the Upper East Side of Manhattan. Each hospital has its own emergency management program run by an incident management team. The health system uses an emergency operations center model. I'm not going to get into the detail of that as to why we use that model, but this, suffice it to say, this is the Emergency Operations Center, and this is the first day that we activated on March 5th. If you look around the room, there is only one person of color, and it's somebody of Latino extraction, and that's something that I think is going to be relevant for the conversation later on. In order to organize ourselves, we split ourselves up into a series of work groups. First one was clinical operations, looking at both ambulatory care and emergency medicine. Then we also had clinical operations looking at inpatient care, crisis communications, supply chain, staffing, policy aimed at non-clinical policy, information technology, blood bank and laboratory, support services made up of an array of different kinds of support services. And then an afterthought was actually discharge planning, and that only occurred to us when we started having difficulty discharging patients because facilities wouldn't take them. After a few days, we realized that having separate clinical operations teams probably wasn't going to be effective. We combined them into a crisis standards of care group because that's how we started to manage, knowing that we couldn't provide care the way we would during peacetime. Initially, staffing was focused primarily on nursing, respiratory therapists, lab techs, et cetera, and no attention was paid for licensed independent practitioners. After a couple of weeks, though, we recognized that we really needed to focus on ensuring we had sufficient physicians, PAs, NPs, and actually CRNAs, which I'll talk about in a few minutes. Today's talk is going to focus on the crisis standards of care and staffing for LIPs. On March 23rd, so we're now 2 full weeks into the pandemic, this was our situation. We were already in a crisis mode. 50% of our beds already had COVID-19 patients in them. Our baseline ICUs were full. Our hospitals were complaining of being exhausted, and the EDs were already overrun. The departments in the medical school that basically controls the medical staff, there was a concern that some of these departments were actually hiding their staff or protecting them from getting sick. And so we weren't necessarily going to have the resources we needed. The hospitals were trying on their own to support their workforce needs in terms of physicians by looking to see who they could redeploy within the hospitals, but they were doing it without any sort of organized cross-system strategy. Alternate care models were not being considered at that point, and we needed to start working on those. The notion that nurses would only work three 12-hour shifts a week, we started to challenge that supposition. Same thing with PAs and NPs. What are we going to do about having our physicians? And was anybody engaging the voluntary staff? We needed to focus on our critical staff, and that was primarily aimed at emergency departments, our medicine units, the critical care units, of course. Respiratory therapists were something that was being looked at primarily by the critical care folks and our human resources teams. Palliative care was a very important factor. Mount Sinai has a huge palliative care program, but not a huge palliative care workforce. And we had definite needs for more palliative care physicians and social work support. And you'll hear afterwards when Dr. Rip speaks about the behavioral health component. And lastly, we had to also appreciate the breadth of the demand. At the system level, we had to think about the resources that needed to be redeployed across the whole health system to make sure that we had proper coverage for all the patients that were coming in, depending on where they hit. Mount Sinai Brooklyn, our hospital in Brooklyn, and Mount Sinai Queens were very heavily hit, whereas Mount Sinai West, the old Roosevelt Hospital, was hit much later. And so where we needed those resources and where we needed to deploy them, we had to monitor that on a daily basis. On the same day, Governor Cuomo made an announcement. He said, you must increase your capacity by 50%. You must. Mandatory directive from the state, find more beds, use more rooms. You must increase your capacity 50%. What you see in this table is our baseline pre-COVID bed capacity across each of our hospitals. What we did is we took a look to see where we could put more beds. If you see here, Mount Sinai Beth Israel had massive capacity because we had been in the process of closing down many of those beds, whereas other hospitals had a much harder time finding additional space. Ultimately, we were able to increase our capacity and for a system got 64% over our baseline. Here's Beth Israel, 235% over its baseline. Brooklyn could only increase 7%. And we had to figure out how to manage the patients that were going to come in to those spaces. We developed 4 work streams. One was to look at the licensed independent practitioner pool. Another was to look specifically at the staffing demand, both the acute and what we would forecast. We had to come up with alternate staffing care models. And finally, recognize that we would have people working in roles that they had not usually been in, and they would need to be trained up. And how do we get that training done? And of course, this is COVID, so we're not sitting around a table or in a classroom. This would all be remote learning. From the LIP labor pool perspective, we started to look at what we had at our resources. Within our health system, we had our own faculty practice. That was questionable whether or not that would be sufficient because we really had no idea how large the surge would be. At that point, we started getting numbers, and I'll show you some of those in a minute. We actually posted a volunteer portal on our webpage and pushed out notification to the community about coming to the webpage and volunteering. I will tell you that that did not work out well. I wouldn't recommend that other places do that unless you are going to dedicate resources to really sifting through what you get through that kind of a portal. We had the medical staff services database that would be able to match up basically privileges to individuals to try and figure out who could be deployed, but it wasn't necessarily the most efficient way to do it. And then the school had its own labor pool between the house staff and the medical students, and were we able to really tap into that? What we really wanted was a smart database that would be able to provide us the individual skill sets of each practitioner so that we could know what they could do about being deployed. Additionally, we didn't necessarily know who would be available and where they would be available. Who knew what facilities, who were familiar with which facilities, et cetera. And who are we actually going to include? The full-time staff was obvious. The voluntary staff was a big question mark. It actually turned out that our voluntary staff was not particularly helpful, unfortunately. They really looked in on their own patients, but for the huge surge of patients that were coming through the emergency departments and the unassigned, they were not particularly useful. Our advanced practice practitioners were critical. They were some of the earliest people that stepped up to be redeployed. It turned out that students were not helpful. Not that they didn't want to be, but the school took a very protective stance with regard to students, and they were not deployed in the clinical spaces. We did access some of our non-clinical staff, medical assistants in particular, and we actually deployed some of them to be support on certain units, but not to a great extent. Regarding staffing demand, we started to look at specific needs. Our system vice chair for emergency medicine took point on that. Each of the hospitals identified critical care and hospitalist medicine leads to oversee the demand that they had. Pulmonary critical care set up a system level person to oversee that, and similarly palliative care did the same. What we needed was really detailed real-time awareness of what the needs were. So we started out with twice-a-day calls and then moved back to once-a-day calls at 8 in the morning to find out exactly what our staffing arrangement was, what our capacity was, and where we had hotspots. And that worked out to give us some sense of the acute need, but we really needed a better way to forecast. And what turned out to be particularly helpful was the use of CRNAs. And I'll show you the data in a bit. We brought in a huge number of CRNAs because they really are utility players. They could serve, many of them could serve as critical care nurses because they all have to have a critical care nursing background in order to go to CRNA school. Nurse education, respiratory therapy and vent management, intubation teams, and rapid response teams. we actually put teams of CRNAs in some of our emergency departments because there were so many intubations going on that the ED physicians couldn't handle them all. Alternate staffing models, we recognized that we would have a shortage of the physicians that we needed, that the remaining practitioners wouldn't have the necessary skills that were required, and that the number of patients was soaring. So how else can we provide care? What other models can we use? Rather than having people work 12-hour shifts 3 days a week, should we be working more longitudinally? Should we be stretching? How far could we stretch? We reached out to the Uniformed Services University to ask them about what they do for combat fatigue and how long they work, how long they will consider putting soldiers in the field. And believe it or not, they weren't particularly helpful. They didn't have great data. They had data on sleep deprivation, but not how long you could put a soldier in the field before they become ineffective. And so we really were experimenting along the way. One of the care models that we came up with, actually it wasn't ours, but it was developed and published by the head of critical care at Memorial Sloan Kettering. And this is just a graphic that shows it. Basically, you've got one intensivist that can oversee, multiple teams, each team led by another physician with multiple minions underneath them, including critical care nurses, advanced practice providers, and then maybe even non-clinical folks. Therefore, one intensivist could theoretically care for 96 to 100 patients. This was an ideal, and we started to try to roll it out. In fact, we never reached that level of dispersion, but it is something that I think merits a lot of attention and a lot of evaluation. Training up was another component. As I mentioned, we had practitioners who were going to be practicing outside of their scope. So we pulled together a work group, you see that on the left, various expertise to try and figure out exactly what skills and what knowledge needed to be imparted. Figured out how to do that, develop the curricula. So within 1 week, we had developed a full bore curricula and training program for ideally aimed at internists to help them be hospitalists and hospitalists to help them become intensivists. This worked for the house staff as well. Implementation. So exactly where did we get the providers from? And I'm going to show this, that's what this graphic is about. So we're going to start with an example. This is just Mount Sinai Hospital. And so we have at the top, we had our emergency medicine folks, our medicine teams, and our critical care folks. And they basically were staffing everything they could staff. We also then pulled other people from the Department of Medicine and deployed them within these same ranks. But then surgery and the surgical specialties, anesthesia and other specialties, radiology, et cetera, stepped up and said that they would help out and make themselves available. So we then started feeding those individuals into the medicine teams that you see above. We did the same thing for Mount Sinai Morningside, Mount Sinai West, and Mount Sinai Beth Israel, basically pulling from within those hospitals the resources that they had that were not actually working. Again, elective surgery was canceled, so the anesthesiologists and the surgeons were available. At Mount Sinai Queens, Brooklyn, and South Nassau, the other three acute care hospitals, we had our emergency medicine and hospitals and intensivist cohorts. There weren't really sufficient surgical resources to really make a difference. We needed additional support for those hospitals. So we went to our Mount Sinai network, which is largely internal medicine, all over the greater metro area that work in ambulatory care. And we took those folks and we distributed them amongst Mount Sinai Queens, Brooklyn, and South Nassau. All the hospital-based practices went over to South Nassau, and the ones closer to the urban region went to Queens and Brooklyn. And that was an extremely effective workforce. Anybody who was left over, who was largely from Mount Sinai, fed into a labor pool that we started to develop. And that included emergency medicine physicians, critical care, and generalists. Now, we didn't have necessarily a lot of those, but we started to pull them because we realized there were more there than we needed at Mount Sinai Hospital. But we had to figure out who was available. We couldn't double dip and pull the same practitioner to multiple different areas. And so we needed to coordinate. And that coordination was done by a deployment team that would consider the site and service where the person, an individual might be needed, whether or not they would go as an individual or part as a team, whether or not they needed supplies, and if supplies, where would we get them? And finally, what was the schedule going to be? When were they going to work? What could they expect? Because we were sending people to hospitals they had never been to before. And this was managed by the system vice chair for emergency medicine, the system director for hospital medicine, and the system division chief for pulmonary critical care. And they took this pool and decided who was going to go where, and then deployed those individuals back to the hospitals where we needed them. That still was insufficient, and I'll show you that in a minute. And so we had to go to external resources. The external resources were comprised of volunteers. I mentioned that portal. Very few people actually came as volunteers. Locum tenens agencies that we reached out to proactively. Some of them reached out to us, but we reached out proactively. But most importantly, we went to individual physician groups, national physician groups, oftentimes either emergency medicine staffing groups or anesthesia staffing groups. And we contracted to bring in their providers. But we had to vet them. We had to determine whether or not they were, would meet our needs. And so we set up a vetting group that was made up of the individuals you can see in that box. And then we would process them because each of those had to get disaster privileges. So we had to go through a credentialing and onboarding and orientation program for them. Those individuals are then fed into the labor pool, which were then fed to the deployment team, and they were then fed to the various hospitals where they were needed. Now, we built this entire mechanism over a period of about 7, maybe 10 days, and through iteration. And I was extremely gratified for the help that we got in doing this. It was quite an undertaking. Now, how much did we need that help? What you see here is the forecast that we had generated ourselves. There were forecasts coming from all over the place, but we had our own epidemiology group doing our forecasts. And what you see is these are individual hospitals. Early in the pandemic, and this is now March 30th, March 31st maybe, you can see that Mount Sinai Hospital was predicted to have over 3,500 patients. Now, you can't see the table, but Mount Sinai Hospital doesn't have anywhere near that number of beds. It's got 900 beds. And this is where I was living right here. I was literally in a state of panic. What are we going to do when this hits? Because this is what the projection was. Well, fortunately, that's not what happened. What happened was this. And rather than the peak being at the end of April on the 20th or so, which is what was predicted, and it would have been off my screen, the peak occurred on April 6th. And we only reached a total of 2,000 patients for the entire system. Now, how did that compare to what we needed? Well, firstly, we didn't actually exceed our baseline number of total beds. So even though we had to increase our total number of beds by 50%, and we got to 3,078 beds, we didn't really need them. What we needed was practitioners, because we didn't have practitioners to do that. Our EDs were overrun, the surgical beds were filled with medicine patients. So while we had surgeons, we didn't have enough hospitalists or intensivists. And here you see our actual critical care need. The critical care balanced out. We had at the roughly 450 or more, 475 critical care patients at one time. Our baseline number of critical care beds is only 243. So that's where we really needed to have the additional beds created. It was critical care beds, and even more importantly, intensivists, critical care nurses, respiratory therapists, et cetera. And I think that's what all of our area hospitals saw, and that's what the folks who were listening probably saw. These are some of the practitioners that we pulled from outside the health system and redeployed. You can see the majority were anesthesiologists, critical care docs, emergency medicine, some family medicine, interestingly, infectious disease, and internal medicine. The CRNAs, we actually deployed 121 external CRNAs. When you look at the total numbers deployed, 369 practitioners, these people were getting paid a premium to work these shifts. The cost was outrageous. Now, how well did we do at matching the demand with the supply of practitioners? Well, these are the numbers of patients that we had in our hospitals over the time of the pandemic. these are the number of deployed external practitioners that we brought in. And you can see that we got off to a slow start. We didn't react as quickly as we needed to. In here are actually our own internal deployment of our own staff, so it's not as bad as it looks. This is where the major expense and waste was, in that we had all of these practitioners still here, still on contract, committed to be in New York, living in hotels, that we were paying a premium while the numbers were coming down. But of course, we didn't know the numbers were going to come down. Each day they came down, was news to us. Because remember, we were predicted to have a peak that was going to hit somewhere over here. Let's talk specifically about scarce resource allocation, and then I'm going to hand it over to Dr. Rip. One of the things that was a major concern for the public was what would happen if we ran out of ventilators. And since this talk is about resources, we took a hard look about what we would do if we run out of ventilators. We actually developed triggers to help us understand what was going to be the need to implement some sort of pull a trigger in terms of a plan. This is how we did. This is as close as we came. 93% of the ventilators at Mount Sinai Brooklyn were in service. If the numbers had spiked a little bit further, and again, because the curve fell down, we didn't reach this, but we easily could have exceeded our number of ventilators. And these were some of the plans we had for what we would do about it: sharing ventilators between two patients, changing the policies regarding utilization of equipment for the ventilators, using alternative respiratory therapy needs, palliative care so that we wouldn't ventilate patients who wouldn't benefit from it, and then moving ventilators around the health system. That we did quite a lot of. When I show you these numbers here, this was not a static number. This changed depending on need in terms of where we put the ventilators. John, I'll be ready in just a couple of minutes. We had a clinical triage team that looked at what we would do and if we needed to actually start to ration. And the one thing that I want to point out, and this turned up as I was putting this talk together, we got guidance from the state, from our peer institutions and literature about what you do about rationing, how you make the decisions, how you ration resources. We pulled together a multidisciplinary stakeholder group. The group we did not include was our Office for Diversity and Inclusion. And I spoke with the person who led this effort for us, who himself is actually is a man of color. And it didn't even occur to us to include them, nor do we probably right now think about proactively including them when we build programs for healthcare, let alone in dire need during a disaster. Although we did want to address equity and fairness, having them involved probably would have been worthwhile. This was the methodology we would use if, in fact, we had to actually ration. And fortunately, we didn't have to do that. In summary, despite being aware of the pandemic, we did get off to a slow start. I think everybody in the area got off to a slow start. I don't think anybody conceived of the volume what we would see. Ramping up our LFP operations, staffing operations, I think was heroic. I really appreciate the help that we got. Accurate planning for staffing needs was impossible. And that's where all the waste developed. The costs were staggering, scarce resource allocation. I think we did a pretty good job of thinking through, but we never really needed to implement it. And I think that warrants additional research. Thanks.
Great. Looks like great. Yeah. Hi, everybody, and thank you for this opportunity. It's really a pleasure and a privilege to be here with you today, especially to follow Dr. Knapp and to hear that presentation and be reminded of what it is that we went through as a system, as a community. It is really quite remarkable. Even though he captured it in 20, 25 minutes, it's really, it's hard to capture, I think, just because of all that was involved and took place. I'm going to spend the next few minutes chatting with you about how all of this specifically addressed issues around well-being, and how we as a community, as a workforce, as a group of leaders in the well-being space came together to provide for our own. And much of that effort was thankfully supported and heralded by Dr. Knapp, who really enabled us to be in a place to do some good. If you could go to the next slide, please. So what I intend to do for you is talk about how that pandemic impacted the emotional well-being of our workforce, identify some of the changes needed to physician well-being as we sort of move forward, make the case for continuing to prioritize physician well-being, and finish off with a bit about resources available. Next slide. I put this up here to demonstrate for you how we thought about well-being prior to COVID. And when I say we, I oversee an Office of Wellbeing and Resilience at Mount Sinai, where for some time leading up to this pandemic, we were organizing a concerted effort to maximize the professional fulfillment, meaning, and work that our workforce derives. And do so recognizing that it's a critical component, it's a critical outcome, because it touches on so many other things that a healthcare system is trying to do in terms of its goals and optimal functioning. And so you see, there's a number of places that we focus. Much of our interest was on the system, enabling to create a system that enables the workforce to get its work done. And there was a bit of a pivot that happened in COVID, but certainly a focus on a workplace culture and a workplace that's efficient and functioning was central prior to COVID. It still remains a central tenet, but the idea here is if you enable people to get their work done, most of us derive meaning from the job itself if we're in healthcare. And if we're enabled, then we're gonna derive more meaning from it. Next slide, please. This is just one reason, one figure rather, that captures the many reasons why it's important to pay attention to well-being. Again, this is a model that precedes COVID, but certainly there's personal and professional consequences that inform our desire and have led to the momentum behind recognizing the importance of well-being. And certainly you see on the right side there, the professional consequences speak to what I was alluding to around why it's important for a health system to keep the well-being of its workforce in mind if you want to promote, high quality care, decrease errors, increase patient satisfaction, and be productive and retain your workforce. Certainly there's plenty of personal consequences to the individuals who make up your workforce that also, and perhaps in and of itself, is an important reason to elevate the platform as it relates to addressing well-being. Next slide, please. So I want to take you through what the pandemic that Dr. Knapp, some of his curves there. There's sort of a parallel curve, if you will, around the major stressor of the day, based on the phase of the surge we experienced. And for those of us in the well-being space, this is what we were dealing with at the time. And so in the beginning, when we were hearing about those projections of what's to come and experiencing the disruption to society that we all experienced, we were really we were thinking about our basic needs. And when this was a bit of a change for those of us that are focused on well-being, because these are usually tended to on a regular basis or largely addressed with some notable exceptions. But you don't, in terms of where you get your next meal and childcare, which remains challenging for the country, but even prior to a pandemic, it became, and for many of us remains, we're acutely aware of the challenges, but these became much more elevated in importance for those individuals that comprise the workforce. Just getting to and from work, and then of course keeping yourself safe, basic safety Obviously, we maybe not things that were thought of on a day-to-day basis prior to the pandemic, but all of a sudden that became a huge issue, whether it related to sufficiency of PPE or fears around being exposed and bringing it home. So there was a lot of need to address basic needs, and then uncertainty. I put that near the plateau. I think certainly leading up to the peak, and probably infused throughout all the phases. Quite frankly, uncertainty. If there's one lesson that was most salient for me, was the power of uncertainty to lead to anxiety and stress and affect the workforce, the well-being of the workforce. And certainly, as we were leading into the surge and the projections that Dr. Knapp put up there, not knowing what's coming, fears about allocation of resources and being redeployed were really setting in. And then there were other things that you may not have thought about. There was those people who were essentially sidelined. Now the guilt of wondering, am I doing enough? Maybe could I be doing more? Also was a stressor. And then questions around, will I be supported, and just how will I be able to manage in the current work environment? We're now in sort of a different phase now that we've come down to low prevalence, where there's a lot of processing going on and has gone on and continues to go on. And certainly this is when we think about, this is when we take a breath and we experience, we reflect on the grief and the loss. And I think it's fair to say that nobody who, was part of our workforce was untouched by this in some shape or form, some in a very powerful, personal, and deep way. So it was in this phase that, the grief and loss was being processed and continues. For some, for many, they needed support. For some, they will need treatment. And PTSD is a very real consequence of what we've experienced. And certainly issues around depression and anxiety are very real. There's also, overlay that with the societal upheaval and attention to racial injustice. For some, that issue became the most important as it relates to what's affecting their well-being. For some, it interacted with all of these other drivers. And I think we're in that phase. We're sort of in the processing phase now. For many, this will take some time. And I think now what we're going to see also is remaining uncertainty. Certainly issues around childcare, reopening of the schools, issues around how the health system will withstand what we've been through, and what changes will be seen as a result of that. Creates a lot of uncertainty, and that's very much where we are now. Next slide, please. As it relates to our strategies to address it, I was part of a group, a task force that came together. Dr. Knapp enabled us to bring all the many stakeholders across our health system who formerly had a role that could be brought to bear in terms of addressing these stressors. And that task force got to work to address each of those major stressors as the crisis and the sort of following the curve as it unfolded. And so in the beginning, there was a lot of attention to providing basic daily resources, creating places where people could get food, to get resources around childcare, transportation, and parking. Not only providing the resources, but a lot of it was providing the information, which speaks to my next point. At certain points, the need to provide clarity around PPE was the most salient issue that was happening. Certainly, as the uncertainty mounted, the answer was to provide authentic, honest, regular communication. This was done by a huge effort. As Dr. Knapp mentioned, there was a crisis communications team. At times, we had a role in providing some input as it relates to ways in which those messages might alleviate some of the anxieties or uncertainties. And in addition, we layered in weekly wellness messages about which really was, how strategies to cope, and just multiple ways in which these messages were delivered, not just daily emails, but frequent town halls. Now that we're in that sort of processing phase, there was a need, and there remains a need, and we can speak to it if of interest. But we ramped up a lot of services in the midst of the surge, some of which have sunset, some of which have remained, and some of which were in existence but required more coherence around how they could be delivered to the workforce and for what reason. And so those took the shape, many different forms: support groups. There was a crisis 24/7 crisis phone line. Psychiatry, provided telehealth to our own, and there was a significant increase of referrals from within our own workforce, and of course there was much more. What we have here is mental health PPE. That was what we had in terms of groups that were mental health providers who proactively went out and reached out. We called them our liaisons. They went and proactively contacted individuals who were working, and we organized a system to do that out of the principle that there might be people who are just not reaching out but are in distress. And Frontline Relief was providing a lot of those resources right at the place of work. Next slide, please. I'll gloss through this. I'll just point out that we published on these stressors and kind of came up with this model as it relates to what it was that was the major sources of anxiety, and kind of broke it down into this categorization of hear me, protect me, prepare me, support me, and care for me. And I think what that speaks to is what people really want and need, certainly in the midst of a crisis. And so this is one nice way we think of sort of capturing that. Next slide. Another piece, if of interest, that sort of characterizes our efforts addressing basic needs, communications, and the psychosocial mental health supports is in this reference here, attending to the emotional well-being of the healthcare workforce. And I put on as a figure this sort of modified Maslow's hierarchy, which sort of shows you how in times of crisis you work your way down, and it's really about basics and safety. That if we're not tending to those, then you can't kind of work your way up. We want to be appreciated, and we want to heal patients and contribute. But if we're not meeting our basic needs and we're not feeling safe, it's awfully hard to do that. Next slide. So I spoke to how, thank you, I just saw the note on time. I thought I had 1 minute left, so glad to know I have a couple more. In terms of those three basic areas, kind of mirroring the main stressors of the time, we were fortunate that the communications team put and our digital health folks and our website people put all their efforts into creating a new website that was meant to provide resources for our own community. And we had a dedicated well-being staff resources page, and which was just an enormous help and speaks to the need for communication and really the recognition of the need for communication, which was just central and critically important. And so for each of on this web page, we created three areas that our workforce could look for their basic needs and self-care, their mental health and psychosocial support, and then on the ground support, that sort of frontline relief I spoke to, of bringing resources to the places where people are working. Next slide. Here you just see a little more how we organized it. So just giving you a little bit of detail as an example of our experience and what we did. The redacted area there is a phone number. Speaking of resources that were put in place and then sunset, our medical students actually served a role here in staffing a phone line where if you didn't want to go through a website and you wanted to have some help navigating all the many resources that could be provided to you, you could call a phone number. And there would be a person on the other end who would basically know all the content on this website and could direct the individual to the resource that was best fitting. And this is how we kind of organize things. You can see by basic needs and self-care. And then the mental health and psychosocial support, we did kind of have a learning, some learning curve here in that we first kind of organized it a little differently, sort of in the way that we as you know, in the mental health and behavioral health space, think about the different categorizations. And then we shifted to what you see here, which is thinking, okay, what is the user, what is the staffer, what is the employee going to want to see when they look here. And so we organized it in terms of crisis support, one-on-one, group-based support, spiritual care, general well-being tips and strategies, and then additional resources. Interestingly, the additional resources are sort of outside of our own health system, recognizing that there's always going to be a segment of our workforce that, you know, no matter how good a job you do on communicating, on supporting, on providing resources, on sharing a supportive message, there's always going to be individuals that just, you know, want to be seen outside of your own system. And so there was a deluge of these resources, and it required some vetting to make sure that those that we included were valid, but that was captured here. Next slide, please. Our frontline relief program was really a wonderful program that developed in the midst of all this, and thanks to a gift from our Coleman Family Institute, we were able to bring these snack stations and these well-being centers, now called recharge rooms, which is a durable product of the pandemic and will remain. And these were both the snack stations. You know, people were in their PPE. The you know, cafeteria was limited in terms of what could be when and, you know, what people could get, and getting outside to get food. It was a real limitation. So we brought the snacks to them, as you can see here. And I also, another lesson learned, just these simple measures. You know, sometimes just showing it's really that, you know, care for me element of what was in the JAMA paper there. But, you know, we show that we care sometimes by giving food, and people really resonated with this. Just something to say, you know, we appreciate what you're doing, we recognize what you're doing, here's something for you. But beyond that are these interactive recharge rooms, these incredible places. If you see the picture there, if it looks like that's the rainforest, that's what it feels like when you enter these rooms, which are sort of these immersive sight, sound, music, scent, meditative, visual elements. You know, you really feel, even in 5 to 10 minutes, that you've been brought to another place, and they're remarkable. And they've made their way across our health system, and we will work to keep them there because we think they have great value, you know, whether there's a pandemic or not. Of course, when the dog visits, everybody's happy. So we had our dog go to these places as well, our facility dog. Next slide. So, I'm just to kind of conclude, you know, I think you heard, we started by hearing sort of what are the elements of an emergency response, and from Dr. Knapp and all the pieces. You know, I think there was a strong argument to be made for well-being prior to COVID, and, you know, that builds on the evidence around all those consequences that I shared with you, both personal and professional. And I often would be making the case for well-being, that it's about, there's a regulatory case from our graduate medical education regulatory bodies. There's the moral imperative for the individual who's in crisis, who's suffering. There's concern, obviously, about physician suicide being higher than the general population. There's a business case to be made that if you invest in well-being, you'll see a return through retention. And this was the case we were making beforehand. Next slide, please. You know, I make the argument that you know, now more than ever, well-being is critical, and you see all these pieces that capture that. And there's been an increasing recognition that this is taking its toll on our workforce. That the mental health is real, and we've seen that through some survey data that's yet to be published from our own system. And so, you know, I think now more than ever we need to pay attention to this stuff. I think places that have the infrastructure in place are enabled, and I feel very fortunate to have been at a health system that had some infrastructure that I was involved in to bring to bear and partner across the system to provide resources to ramp them up in a time of need. So hopefully now this will be sort of part and parcel with as we think about emergency response, that this is something that is part and parcel. Next slide. So I think this is my last slide. You know, I think clearly there was a need to pivot. You know, hopefully you saw that you know, things like attending to basic needs and providing frontline relief and so forth. A lot of the communications and cultural components of well-being, which we did pay attention to and were part of an effort prior to COVID, became much more important in the midst of a crisis. And I think though we're going to pivot back to some of the things we were doing beforehand, that's going to remain important in this post initial acute surge phase. Certainly there's going to be some people that have long-term consequences, which again, I mentioned, we saw a large burden of symptoms of PTSD, depression, and anxiety. And so while everybody needed support during the time, and hopefully the services we provide layered on support, some will need treatment. And so fortunately, we have a new Center for Stress, Resilience, and Personal Growth, which is providing screenings and referrals and some treatment to our workforce who, as a result of COVID. And this is a longstanding, durable product of what we've been through and recognition of those changes. So with that, I will just finish by again saying there's lots of resources to help for support. Please think of me as a resource if you're interested in hearing more. I think I made the point about communications, although that too will remain critical, I believe, as we continue to experience the stressors, the long-lasting impact and stressors of this pandemic. It'll be critically important that we maintain all that communication that was authentic and transparent will be necessary in this next phase and can't be overemphasized. And with that, I'll conclude and thank you for the opportunity.
Well, I want to thank both Dr. Knapp and Dr. Rip for their presentations. Again, our aim was really to get inside this crisis in many different ways. And I think that this, as we heard you describe what you are attempting to do real time in days, it's just an amazing, amazing venture. And to serve so many people, so many New Yorkers, just amazing. You know, I'd like to kick off the questions with one that I had as you were speaking. I had many questions, but the town halls for the staff, that's something that has been happening at Healthfirst, mostly following the murder of George Floyd and, you know, the social justice issues as Errol mentioned early on. What are some themes that you have found from those staff town halls?
I think that question was probably directed at me, although I have no doubt Dr. Knapp has some.
Either of you, both of you would be fine.
Okay, Mark, maybe I'll field it first.
Sure, go ahead.
You know, I think we recently had an anti-racism town hall, you know, specifically addressing this. That the issue is huge for all of us, and it's not going away. And we had a town hall as one way of addressing that. Certainly, you know, I had the opportunity to participate in a couple. They were doing these pretty much weekly in the midst, and they sort of crossed the School of Medicine and the hospitals, and so they were open to all, you know, accessible to all staff. Certainly, in the midst of the pandemic, there was a lot of it was focused on, you know, on sort of what can we expect and trying to address the uncertainty, right? And you know, questions about testing and resources and redeployment and a lot of infection control questions and so forth. You know, and then I think there were a couple that I attended to sort of make sure people were aware of well-being. So from my standpoint, you know, specifically resources, you know, making people aware of resources as a theme. I would just add, I think I would think of it as one tool in what should be, you know, when it comes to communication, particularly in the well-being space, I tend to feel it's pretty hard to over communicate certain things. And so a town hall is one mechanism. If you rely on one mechanism to reach people, you're not, you know, you're probably going to be limited in your reach. So that's why emails and the website and town halls and sort of a multi, you know, probably social media and so forth, a multimedia means of reaching people with important messages is the way to do it. The town hall was one of them. I don't know, Mark, if you have anything to add.
No, I think having a crisis communication plan is obviously important in any situation. And I think that we stumbled a little bit in the beginning trying to figure out how to communicate best with our workforce about any of the aspects that this brought on. What I wanted to comment, though, Dr. Bean, in terms of your question, was the timing of how all this played out. As we were coming down from the surge, and people were sort of breathing a sigh of relief that the worst was over from a acute infection perspective and management of the hospitals and people's livelihoods, et cetera. And I think we were eager to start really addressing the wellness piece that John was talking about and really focus on what had people been through, how do they deal with this? How do they, basically, how do they address the ongoing issues that are likely to crop up as they reflect and as time passes? And just as that happened, George Floyd was murdered. And the population, unrelated to healthcare, became extremely focused, rightfully so, on racism and what's been going on for decades and millennia and centuries. And it created a challenge, I guess, for us as leadership on how to address both the need to address people's exhaustion and the PTSD concerns from COVID, and be respectful of the fact that we have a real crisis that's not related to COVID, that's going to be a lot harder to fix, that is, has whole political implications that we really need to take on. And I think the town halls were a good way to, first of all, symbolically say that we want to have the conversation in a way that we never had before. I mean, I am horrified that George Floyd was murdered and that happened. I have become so much more educated on racism in ways that I never would have appreciated as a result of that. Our whole health system has been focused on this. And I think we could probably do a whole nother half day on that. And maybe Healthfirst wants to do that. I'm not sure how that fits into the strategic plan. But it's a conversation we have to have, and it's a conversation that we have to continue to have in ways that people like me never knew. So I'm grateful for the ability to even have these town halls, or to have the educational sessions that we're having with ourselves to talk about it.
Thank you so much. I think you answered the question that I meant. I really appreciate your candor, and Jonathan put it in his slide, the transparency. I think this is a lesson that we have learned from both of these, horrible pandemics, if you will. And I think I really appreciate both of you for that. We have a question, Helen?
Yes, we do, Susan. More an invitation. So this is from A. Sawyer. And the question is, can my program invite you to one of our convocations for the nurses schools? So I'll have both gentlemen answer that question.
I'm sorry, I didn't really hear the question. Could you just repeat it?
I think, yeah, this is an invitation to one or both of you to be a part of the convocation of nurses at a nursing school, and we will share that specific information with you after.
I'm sure they're really speaking to John.
Okay.
Although if John
that
was
cheap
flat,
wellness that really.
I take my glasses off, John and I look exactly the same. So.
So that question will go into Jonathan's box, I guess. Will we have
Yeah, we'll send that directly. That's awesome. What a nice thing.
Thank you.
Yeah.
Absolutely. So the next question is from Gay. So SDOH embodies diversity, equity, and inclusion. What commitments are being considered in the Mount Sinai health system towards diversity and inclusion, which we have seen is an issue nationwide with COVID?
John, you want to go first, or?
Yeah,
Go ahead.
So, I mean, I think Dr. Knapp, sort of summarized where, sort of where our leadership is at with this issue. And it's quite clear that this is very much front of mind. And there's a desire to not just talk, a desire to not just learn, but the desire to do something about it. Probably the most concrete example is there's a very large anti-racism task force that has launched, that is underway, and the intent of this group is really to create some guidelines for the system in terms of actionable steps that can be taken. I will say that that while Mount Sinai has clearly been committed to diversity, again, before the pandemic and before the recent sort of increased appropriate attention to racial injustice, I mean, there were clearly efforts. So in a way, the existence of that framework has set us up to take it to the next level, which we need to do. And I think our eyes have been open. I know mine have. But in terms of a concrete way of sort of taking that next level, there's sort of a structure and a process underway.
And what I would say is something that I've heard said a number of times is that organizations don't change, people change. And we're an organization of 42,000 people. And a good number of our people already know that this is an issue and have lived with this their entire lives. Unfortunately, there's a significant number of people in our organization for whom this is a revelation. I mean, they've heard about it, but they've never really understood it. I've learned I've got 3 daughters. 2 of them, of their own volition, took African-American studies in college because they wanted to learn more. And they've been educating me along the way, and we've been focused on educating our leadership. We have something called the Quality Leadership Council, which is probably about 60 or 70 people who really lead the health system that have been meeting and talking about this and breaking into Zoom chat rooms and challenging ourselves. And I think that's what this is going to take. I think each of us has to really recognize this. And I, for one, feel better about it. I have a curiosity. I have a desire to do something. And I don't see that ever going away. I sort of feel like I'm a convert. So, but it's individuals. And so what John said is, yes, we have a task force, but the task force has to focus on addressing individuals. And in my hometown, I live in a nice community up in Westchester. And people are still burning signs that say Black Lives Matter. I don't get it. I just don't get it. And it's just going to take, relentless pursuit of the ideal.
Thank you. Thank you. We have 2 other questions. Helen.
Yes, thank you. The next question is from Maya. And she says, thank you both for being there for providers and staff. And her question is, as part of staff wellness, was time built into the day or week for team debriefing together, or taking a moment to process the events at the end of a shift, both for wellness as well as improving processes?
Great. Yeah, thank you for that question. I love the question because it both enables me to highlight some of the things we do and also speaks to a challenge that we still need to meet. so we actually, Mark included, I mean, we talked about this in the midst of the crisis that, for example, there were many of us who were very concerned about the toll this was taking on the workforce, just, all the conditions that you've heard about and that we know about, and that we've seen the consequences of. We were very concerned, from an early phase, and created a lot of resources. And we tried, as we were sort of looking at some of the utilization of these resources, we were noticing that there wasn't, and this doesn't exactly answer your question, but by way of background, we noticed there wasn't a huge increase in uptick in the midst of the crisis phase. And what we, on the one hand, we were a little concerned. On the other hand, what we learned from our behavioral health experts is that, in the midst of a crisis where you're just trying to get through the day, you may not actually want to take a pause. This idea that we have these people, these mental health liaisons who would show up on the wards and ask, maybe ask people how you're doing, or let them know that we're here. And people are they're just trying to survive, right? So when you're in survival mode, it's hard to pause and reflect, which doesn't mean we shouldn't think about how to do that. There's a lot of things that we did provide to enable that. One example, again, speaking to the importance of an infrastructure for this stuff to enable you prior to a crisis that enables you in the midst of it. We had these facilitated group discussions with expert leaders who could guide people around a topic and a group and enable a debrief essentially. And so we had to convert all that to a virtual-based format and create a virtual-based guide for the leaders of these sessions. And we conducted many of these, and that was an example of a way to create a space for debriefing. It required groups to reach out and say, we want this. And there was some conversation, do you just provide this to everyone? And there's some reason to believe if you do, it may actually backfire. There's some examples of this from 9/11 with first responders, that they were all kind of made to sit in some debrief groups, and it actually backfired. So I guess what I would say is we do need to build this in. We need to make it part of the culture. There's more work to be done there. But that hopefully answers your question somewhat to the things that we did, and also how to think about it in the midst of a crisis, because it's sometimes you think we just got to, we got to do this, but you might need to take a pause, which can be hard to do.
Can I jump in as well on this one? So first off, hello, Maya. The two things that we got from our discussions with the Uniformed Services University for Health Services. One was that battle buddies, the concept of having somebody who is your person to reach out to if you have any issues. Just having one person that you know that you can talk to, count on, et cetera. That's one. The other was this notion of tapping in and tapping out, or having a debriefing with your team. And we discussed, actually John and the rest of our behavioral health resources group talked about what would it take to implement that. And it would have, and we decided, I decided not to pursue it aggressively because I felt that we would probably not have gotten tremendous buy-in. Now, how do you in fact get people who aren't used to doing something in the middle of this? As John was just saying, they have to be in the right mindset to want to try and do this, and even acknowledge that it would be helpful. How do you build that into the day when people are exhausted, they just want to get home, they just want to, protect their families, whatever the issue is. But I absolutely believe that if we could do this again, there are some resilience tools we would build in upfront. And we should probably be thinking about, how do we do that? What do we build into the start of the day? Now, nurses have a little bit of a huddle at the start of their shift with handoff. It's not a stretch to think that they could build that in to their morning huddle. Physicians don't do that, at least not in my experience. They don't take the time, they don't see the value, they just get going. And I think we have a lot to learn about, what are the tools we need. But I do believe that sitting and reflecting on what happened over the past 12 hours, what we're going to be facing, how we're going to get through the day is really important.
So important. Thank you so much for that. And thank you for the question, Maya. Well, I am really really thankful to all of our faculty, to all of you who participated and were willing to interact and share with us your questions, but also your thoughts and your feedback. All of the presenters have their information available in your booklet, and I do encourage you, if you do have remaining questions, to reach out to them. And this will bring us to the end of today's conference. Again, one more time, I thank you, all of our faculty for sharing your expertise and your experience with us today. And Jonathan, it has been a pleasure moderating with you, and I will turn it over to you to close us out.
Okay, thank you, Susan, likewise. And thanks again to all the participants for a fantastic conference today. Just a note to claim CME credits for the event. All eligible participants will receive an email with instructions. The activity qualifies for up to 5 CME credits. So please claim only the credit commensurate with the extent of your participation. So thanks again, and thanks to all of you for your work in confronting the new reality of COVID-19 and tackling the very old pandemic of racism and the health disparities associated with it. So with that, today's session is officially complete. We look forward to seeing you at our follow-up CME conference in September. So take care and stay safe.
Thanks, everyone.